Okay, welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of this meeting, or chairperson as we now say actually of this committee. Before we start, I have some important housekeeping for everyone. Can you please ensure that your mobile phones are on silent? We're not expecting any fire drills, so if the fire alarm does go off, please follow Nikki. Please keep your microphones muted when you aren't speaking and unmute and speak. As chair, I'll call on those to speak during the meeting. Fantastic. Right. So we're going to move on to the agenda. Do we have any apologies for absence?
Chair, we've had apologies from Councillor Cawthorne, who will be arriving a little late.
Okay, thank you. Do you have any declarations of interest? Nope. Fantastic. The minutes from the 21st even of November. Does anyone have any comments on the accuracy of the minutes? We're all agreed? Fantastic, that's really good. And everything we're discussing is in public, isn't it? Fantastic. Okay, right, so we as a committee have got quite a busy meeting today, even beyond our normal very busyness on the health updates. So I am going to implement some timings, and I'm going to be a strict, disciplined chairman. I hope I am anyway. But if you're as good as my children, you'll get around that quite easily, but let's see. So what I was thinking of doing is that everybody who gives a presentation, limiting it to 7 minutes, and I'll give a 5-minute, you've only got 2 minutes left. I realise I've just said this right now, right here, so please don't worry about the time, or if I cut you off at some certain point, it's, you know, I should have given everyone warning, but I think that helps in terms of getting through things. For committee members, 2 questions per thing, try and limit it. What I'll do is roughly have about 10 per subject, so if we do get through it quite quickly and there's some time left, I'll say anybody wants 3 questions. So think about what the 2 most important questions you want to ask each one. Because we have 9 guests tonight speaking, so we've got to talk about the budget and our report and other things as well. So yes, so that's how I'm going to try and do the meeting. So we're going to see how it goes. Right. The other thing I'm going to do is I'm going to sort of let those who went last time sort of go up the order this time, because you know, I think it's only fair to do that as much as possible. So could we start with Lisa, please, from Hillingdon Health Watch?
Certainly can. Thank you, Chairman. Evening, everybody. I will keep this very brief, as I know there's a lot of people presenting this evening. So, firstly, apologies for the late paper. Hopefully you have a copy in front of you. I'll just quickly run through the last 6 months' figures from our Insight Information and Advice Service. So over 250 residents have contacted us for information and advice. And you'll see there the majority of inquiries were related to primary care, specifically access to services, which generally hasn't changed over the last few years. Hospital and acute care is also fairly high, and that's sort of general issues around sort of booking blood test appointments, but also people needing signposting to the PALS service as well. Some of the issues that we've been hearing about relate to long wait times, lack of response, particularly timely responses to complaints or queries, and keeping family and friends informed about inpatient progress. We've also seen a rise in inquiries coming to us related to access to mental health, community mental health services, and some challenges experienced by patients, and also transport issues to appointments for those with mobility difficulties. Contact regarding social care issues have increased, and we probably need to look a bit more closely at those, and just sort of try and work out actually what are the issues that are arising. Dental care inquiries, interestingly, have gone down, and we're hearing more from people who have been able to access NHS appointments. So that does seem to be improving locally, and we've signposted a number of people to PALS at the hospital, but also Power, who are our local advocacy service, for support with making complaints. Last time I was here, I talked about, I mentioned that we were developing a new reporting system. So we've done that now, and we're currently implementing that. And there's new standardised taxonomy that Healthwatch England have introduced. And we're hoping this will be able to provide us with more detailed and accurate information moving forwards. With regards to community engagement and research, we've been really busy out in the community at various events. We've been running our own community health and wellbeing sessions at warm welcome centres, and we delivered one at Hayes Muslim Centre in October. So outcomes from that programme so far. So we've delivered 7 community sessions. We've engaged with approximately 170 people. And we have referred about 41 people to their GPs for hypertension. We've been collecting feedback on health concerns, and that's going to help us sort of plan future sessions moving forward. We've supported the Hillingdon Hospital and Harefield Hospital place inspections by providing staff and volunteers to provide a patient perspective on the environment. And we've been working with CNWL to carry out some inpatient interviews on mental health wards. We've interviewed 25 patients so far, and the themes that we're interested in are the ward environment, the provision of meals and activities, quality of care, communication with staff, access to information and support, and visiting arrangements. And we're continuing that activity into the new year. In terms of digital outreach, our Facebook and Instagram pages are, footfall to those is growing, and we are about to launch a survey which is about getting a GP appointment. So we're hoping that that's going to increase our reach even further. Volunteering, good news. We've recruited 5 new volunteers over the last 6 months. So they're helping us with all of our community outreach and also with our social media communications as well. And we continue to represent residents at the various strategic commissioning meetings across the borough. Priorities for the next 6 months, as I've mentioned, a review of patient experience of accessing GP appointments. And we're hoping our survey will be going live before the end of January. We are going to review the community health and wellbeing sessions in partnership with public health as the warm welcome centres are developing, and just looking at how we can make those sessions a bit more sustainable for the future. And also, I've just recruited a project officer to support the population health management work on children and young people's mental health services. So yeah, a very busy 6 months ahead.
Fantastic, thank you very much. Yes, the last one's very interesting to us, obviously for other reasons, but all of it's interesting. So the question that I wanted to ask is, obviously, you said that in the report you say that the most common service that you've been contacted about is primary care services, basically GPs, isn't it really? And you've listed some of the problems such as access to services, inquiries regarding complaints procedures. I mean, is there anything else within that data that's of interest, i.e. are there certain areas or specific big issues in certain areas that maybe, are coming up in your research?
That's a really good question. I think that's what we're hoping to identify through the survey that we're about to launch, is sort of really understanding the nuances around what good access looks like for people, what the barriers currently are, and what needs to improve. And also, with our new reporting system, I'm hoping that we're able to break information down by practice as well, so that we can identify, good practice, but also which practices need to improve. And I think that's going to be really helpful, I think, moving forward for the wider system to be able to understand.
We look forward to getting that information. Does anybody else have any questions? Have I scared everyone? No, let's not go.
Thank you, Chair. Thank you, Lisa. Always great to hear from you. Just one question, actually, around the social care issues that you said were an increase, and I just wondered if there was kind of like specific nuances against those as well, because it feels like the same as primary care a little bit. Yeah.
I think that's one of the areas that I really I really need to get some more detail on, because at the moment there isn't a common theme. I think a lot of the issues seem to be sort of where people have been discharged from hospital and there's some miscommunication about the length of time that they will receive social care support for. Doesn't always match with their expectations. So yeah, and there's certainly some, communication issues, I think, with regards to that. But yeah, really not any common themes are coming out of that. So it's something I think, again, we need to probably look at in a little bit more detail, and actually do some more proactive work around trying to understand what people's experiences are and what they're currently experiencing. Thank you.
Tony?
Thank you, Chair. Thank you, Lisa, for your report. Interesting about the dentistry, because it seems to buck the national trend. Yeah. And is there any particular... I know there is quite a good supply in the area, and there's a new one opening just across from the Civic Centre in 1st of February, I think. My dentist is opening. But it's interesting figures, because there's a lot of publicity about it now, and do you see any reason why the inquiries seem to be coming down?
No, we don't actually know the answer to that. I think we were surprised. Whether people have just stopped reporting it could be another reason, because I think more and more people are aware of the issues nationally now. So it could be that people have just stopped raising it as a concern. Or it could be that there has been some improvement. I don't really know the answer to that.
Or maybe people have learned that they can go elsewhere in a sense. So, for example, if you can't get something in Harefield, you could go and sign up with a dentist in Watford, which isn't ideal, but is a solution potentially, for example.
Yeah, absolutely. And I think people are more aware of that now. And it's certainly the advice that we've been giving to people when they call us is, you're not restricted to your local area. You can access dentistry anywhere in the country. So, yeah. So it might just be that, people are feeling a bit more empowered to make different choices.
Brilliant. I have one more question. This is a process question, which obviously is going to send everyone to sleep. But in terms of the information that you collect, 'cause I think Hillingdon Health Watch is great when I speak to you about the information you collect, what you learn. It's so valuable to us as a committee. But what's the feedback loop with service providers? Because obviously you're getting great feedback for those others who are sat in the room about what's going on. And so how do you feed that back in to make sure that our service providers on the ground can sort of get that intelligence and make those improvements?
Well, certainly we take the opportunity, any of the strategic meetings we attend, and any opportunity we get to be in the same room as providers. It's certainly something that I feel we need to look at, actually, where are the opportunities for us moving forward, particularly if we've got more robust data to be able to present. And it's certainly within those meetings, whether there's a regular slot that we could have where we can share information more widely. But yeah, at the moment it's either via a report, which we make public, or via those meetings that we attend on a regular basis.
Great. Any more questions? Excellent. So, thanks, Lisa. Obviously, everyone here, and you are welcome to come in on other people's talks if anything comes up, but thank you very much for that. Okay, next, can I have Derville from Harefield Hospital, please?
Apologies. I will also try and be as brief as I can. So just sort of not a huge amount of change in some... Is it working? The light's on at the bottom. Is that better? Thank you. So I'll try and be as brief as possible. Some things haven't changed an awful lot since the last report that we gave to you, so I'll just update them, and then some other things have changed fairly significantly, and I'll move on to them. So starting with elective recovery, I think like most providers, we're a little bit disappointed with some of the progress we've made. I think particularly for Harefield, Brompton, and of course, you know, we're part of Guy's and St Thomas's now, and for the cardiovascular services there, we have found that the junior doctor strikes have particularly limited us, because during those times we've ended up having to concentrate on emergency services and keeping the wards safe through rotas and everything, particularly at weekends and nights. So that's limited some of our elective progress. However, we are seeing a downward trend in our waiting lists. The one that I think we're most worried about at the moment is potentially our cancer surgery. So you'll be aware we do an awful lot of thoracic surgery for lung cancer. And although that's cast as elective activity, you will see that that's obviously going to be curtailed by strikes. So we're now running regular weekend lists to try and keep on top of that. But it is a concern, and as fast as we are knocking patients off the waiting list, the waiting list is growing. So we are looking at different strategies across all our sites to try and make sure that we use our plant and our theatres to the best of its capacity to get as much activity through as possible. One of the things that we are doing more of since I last spoke to you was the targeted lung health check programme. So this is an initiative across all of London to identify lung cancer at a much earlier stage through a screening process, and the way they identify patients is looking through GP records, looking at certain characteristics, smoking history, age, and several others that I can't name, but I probably should be able to. And what they do, they invite those people to have a chat with a specialist nurse to kind of talk a bit about their history, their medical history. Some of those patients then get invited for a CT scan, and if anything is detected, they will then be forwarded into services for either further specialist diagnostics, which are often interventional biopsies, and indeed could end up having cancer identified and treatment. This activity potentially would have always come to us, but what we're doing is just bringing it forward. So we're trying to get patients at a much earlier stage in London identified for lung cancer, so that the treatment is less severe, because of course we'll be treating people at stages 1 and 2 rather than a later stage where the prognosis isn't going to be good and the treatment's going to be a lot more aggressive for the patient. So that has been trialled in a couple of boroughs over the last while, and it's now being rolled out wider. So we're right in the middle of starting that service up, and a lot of the providers in London, particularly in North West London, are involved in that collaboration. Our heart attack centre remains one of the busiest at London, and I'm sure my colleagues to my left, London Ambulance Service, will agree with that. In terms of the targets that are there in Performance, we're doing pretty well with our door-to-balloon time, and we're pretty much meeting the target of having 90% of patients, the STEMI patients, in the cath lab 60 minutes from the time that they leave their home. We're above the national average, which is floating about 74% at the moment. We are advancing our emergency heart attack care. There's a lot going on at the moment to do with ECMO, and we're trying to identify those patients that are going to go into cardiogenic shock quickly and to treat them accordingly and with good outcomes as well. The transplant service, which as you know is a huge part of Harefield, have had a great year for activity. Over the last few years our activity has dipped for a number of reasons, COVID being one of them, but it is starting to come back up, and only in the last week we've done our first double lung and heart block for several years. Quite rare surgery, because normally it's either heart or lung, so it's really good news that our activity is coming up, and we hope it stays that way. Recruitment. This is the bit that hasn't changed that significantly. We're still having major problems with cardiac physiologists, which are needed for a lot of our procedures. As quickly as we recruit them, they're leaving, and a lot of the time they're leaving for industry. Initially they were leaving for maybe new private hospitals that are being set up across London, but now they seem to be having a much more attractive offer from industry. So what we're trying to do there is still working with the universities and apprenticeships. We are are continuing our recruitment and retention premium for that group. So but to be honest, does that make it more attractive? Probably not, because everyone is doing that, so it doesn't single it out. I think one of the things we can do, and we are doing, is improving the career pathway. There tends to be sort of a disproportionate sort of, as the grades go up through the profession, there is very little, and people tend to have to leave to progress their careers. So we're now working on that premise, that if we can provide better career progression, that we can have people come to us and stay with us, and we develop them, and they enjoy, continuing their career with us. That would be the ideal. So that's the focus we're taking there. Critical care nursing is new to the list of recruitment issues. So at the time I wrote this report, we had 26 whole-time equivalent vacancies, which is a lot for one unit. Granted that we have 90-plus nurses working in critical care. We have huge critical care services.
Can I just wrap you up now?
Yep, certainly.
If there's anything burning that you want to tell us,
No. Just to say that we've got a big open day on Valentine's Day. It's a date everyone will remember, particularly for crit care nurses, and there's been a big interest, so hopeful for that. And then the only remaining thing that continues to be a problem is capital investment, and the fact that the state of our buildings, one of them particularly where we deliver our acute cardiac care, is only got a couple of years left in it, and as of yet we don't have a firm plan as what's happening with that. That's probably the best roundup.
Okay, thank you for that. What are you optimistic about? Because obviously last time you came and talked to us, was more optimistic this time, even though obviously still delivering a very good service. But in terms of these sort of challenges and blockages that you sort of mentioned to us, I mean, or abilities to work around to continue to deliver a service. I mean, what do you think?
So a couple of things I'm optimistic about, and some people might laugh when I say. One is the rollout of our new EPR system. Yes, it's very, very difficult for 6 months after you have an EPR system, but actually we're already beginning to see the sort of information we can get out of there, which is going to particularly aid us research-wise, but also performance where we need to target. But that is probably realistic. We're not going to see those benefits for probably 9 to 12 months from the launch. In terms of the more immediate, we've started we're about a year into it, a big transformation programme to do with critical care, which is going to try and identify all the blockages at once, because historically what happens is you identify a blockage there, you address it, and it moves it to here, and you address that, and it moves back. So we're trying to address it all at once. So that is one of the main reasons why people have their surgery or their complex procedure cancelled. So I'm excited about that, because I can actually see a real change coming our way.
Rita.
Thank you, Chair. Derval, thank you for your report. Just very quickly on recruitment then. When the specialised field, so when the individuals leave, do we do any exit interviews to identify any trends?
Yes, we do. Unfortunately, a lot of our people are leaving to actually leave London, and it's because they're at the stage where they want to buy a property, they want to settle down, they want to have a family, and they can't afford on their salary to buy a property in the area. So that is one of the main reasons. We do an exit questionnaire for every person that leaves, and that analysis is looked at. So our highest reason is career progression and relocation. Some people, it's an invitation from HR rather than just the manager. So if there are problems in a department, or there are problems that we might not be aware of, they are invited to have that with a neutral person as well. But it's a really valuable process. But that's one of the reasons why the cardiac physiology, we're now focusing on career progression, because that was something that was identified.
That's a shame though, because relocation you physically can't do anything with, but career progression I'm sure we can try and work together and see if we can do, because it's a grand job you guys do there, very specialised, so the more we can retain,
absolutely, and also better. To develop a member of staff with those high skills, to then lose them is such a shame.
Thank you. Jude.
Thank you. Deville, is it Deval? Under the staffing level in critical care, the impact on getting more operations done or getting more surgeries done, is that the impact on that because of the critical skills that you require of the staff? How has that impact on the numbers going up and down according to your list here?
So I would say that if you looked at the numbers of cancellations, so most of our cardiac surgery currently goes either through a recovery or an adjacent critical care. So if we haven't got the staff to man that bed safely, there is a potential that someone's surgery could be cancelled. We also have some of our out-of-hospital arrests come directly into critical care after being to cath lab as well. It's not our biggest reason for cancelled operations. Quite often we have people who develop symptoms on the day and therefore they're not suitable for anaesthetic, but it is one of the reasons. So that is why. And also we do go out to agency and we do use temporary staff, but we only will go to a certain percentage of agency staff with substantive in order to ensure that we maintain the safe levels of care, because a lot of the time we are bringing in more general crit care agency than specialised cardiothoracic. So sometimes we can manage to try and spread our staff a little bit more. So for example, if high dependency unit is well staffed and they have empty beds in a day, we will get them to come and support ITU so we can take an extra patient from theatres. But there are occasions, there have been occasions with that many vacancies that on the day you think you're covered for the around-town surgery and 3 people ring in sick, and of course the staffing ratio is 1-to-1 in these areas because a lot of the patients are on ECMO and the like. So yeah, impacting a lot.
Thanks, June. Adam.
Thank you, Chair, and thank you, Devil, as well, for your report. June kind of stole my question. I was going to say, first of all, I think it's amazing that, was it 59 transplants since the beginning of last year?
Yes.
1 a week, pretty much.
Yeah.
Fantastic achievement. My question was, I guess, maybe a bit more specific in terms of the staffing challenges, is how far away are you from a crisis? Or a situation where on sort of a more significant scale you wouldn't be able to deliver everything that you need to do?
So when I wrote this, I wouldn't say we were at a crisis, but I would say I was sufficiently concerned to make sure it's on risk register and everything like that. I checked today and that vacancies is now down to 15, so there is a lot of aggressive recruitment going on, and I think with this open day coming up and the interest that has been shown, I think we've reached the worst and we're on the way up.
Good to hear. And in terms of, so there's some challenges that you've noted in there around Brexit, COVID, etc. Was recruitment in this space always a challenge because of its specialism, and it's just a lot more challenging now than it was? Or was there a time in recent memory where actually things were good?
Yeah, so we had a critical care expansion of 6 beds in 2018-19, and we suddenly had to up the numbers and the establishment of staff. So that was a challenge, but we did get to a point where we had I think it was a 6% vacancy rate, which is pretty standard really. COVID has had a huge effect, and particularly the period after the pandemic. We had a lot of people, the profile of our staff, we had a lot of people that were due to retire in the 2 years during COVID, and they kindly stayed on to support us, but we had a bit of an exodus afterwards. We also had an exodus of people maybe more in the 55 to 65 category, because I think it just made them look at reevaluating their work-life balance and everything. So I think that has contributed, but there are lots of other things contributing as well. So has it been this bad before? I would say when we were trying to do a mass recruitment for increased beds, yes, but apart from that, no.
Thank you.
Thank you. Cecil.
Thank you, Derval. Thank you as always. I just wanted to inquire a little bit about the capital investment, because you brought that last time round about your concerns about your building, and just wondered what kind of mixed bag of investment and funding you would be seeking, and what the plan might be for.
So we're very limited as all organisations by the capital development expenditure limit, where actually everyone gets a lump of capital, but it's nowhere near sufficient to do everything across all the sites. Oak and Acorn ACCU, it's made up of 2 wards, one with level 1 care, one with level 1 and 2 care, which is high dependency unit. They're on that risk register, and there is money allocated to do a feasibility study within the next 12 months to kind of look at what the options are. We are potentially having to look at a brick build to replace those 2 units, and perhaps more in a vertical structure rather than a horizontal. They are porta cabins basically, so they would need replacing. We are also, for all our capital, looking at different ways of funding developments, and that includes, for example, new scanners, new theatre equipment that continually needs to be replaced. Ideally, a lot of it should be replaced every 10 years. We are really stretching that with some of our stuff, and that would be the same at other hospitals. We're not exclusive. So we are starting to be a bit more creative as to how we can get funds to do this when they're not available from central means.
What does that creativity look like, or are you not allowed to share?
No, I can use it. So, for example, with one of our scanners, one of our robots at the moment, we're starting to look, instead of having some capital up front to do the building and bring in the expensive scanning equipment, some of the companies will work with us and say, well, we'll fund it, but what we want is a fee per scan. So it's like a joint business arrangement between the two, but that is likely to be the way to go going forwards.
Thank you. Philip.
Firstly, apologies for my lateness. I've been at Hillingdon Hospital most of the afternoon, but anyway. Thank you for your presentation, Derval. And certainly coming from an HR background, I know that recruitment is one thing, retention is another, so I'm pleased to see that work is being done on that, challenging though it is. My question is really around the issue of engagement with patients, carers, service users, the wider public, and what mechanisms there are within Royal Brompton and Harefield to harness that input, and to what extent are they able to shape your operational programme moving forward? What does it look like for you?
So we actually have a head of patient engagement, and they have a group of team working with them that regularly go around our wards and our departments, both in and out patients, just talking to patients. Yes, encouraging them to do the surveys and everything, but also we pick up a lot of intelligence from just going around and talking to our patients. Our matrons similarly do the same. So the ward is managed by the ward manager, but our matrons are the quality checkers and the people that chat to the patients just to check that everything okay. So that's the more informal stuff that happens at a local level, but there is also the patient representatives that sit on the various committees and groups to make sure that we capture their point of view. That's particularly active and works really well on transplant. Now, it probably works really well there because once you have a transplant, you're under the care of your transplanting organisation for life. So they have a avid interest in making sure that the services kept to a high standard and they're developed. So we are trying to mimic that in other specialties, and we'll find particularly in places like cardiac surgery and through the heart attack centre, people are always very grateful for the care because quite often they see they've been brought back from what they see is almost, I would have died without the care. So they're very keen to give back, which is great. So we have no problem getting patient representatives when we want to do service developments, transformation, to chat to about it.
Brilliant. Okay. Thank you very much, Derval.
Thank you.
And next on my list, and Philip, as you're just recently arrived, I'm limiting speakers to 7 minutes, then committee members to 2 questions. And I'm being firm-ish, anyway, about it. Fantastic. And also, I'm going sort of the opposite way than last time, so I think that's sort of quite fair as well. I've got Clinton on my list, but are we waiting for Chris? We can wait if you...
Chris is on call.
Okay, Clinton, if you... Fantastic.
Thank you, Chair. So, on a positive, we spoke at the previous committee meetings about us transitioning to a team-based working model. So that's where our paramedics are basically working in a group and getting face-to-face briefings with their supervisor, which is something that we were missing in our progress. And that's really, really worked very, very well across the organisation. It's now rolled out across London. And we're eagerly awaiting, which is surprising for most NHS organisations, the NHS survey, staff survey. We've actually had our highest return on that from our staff this year. So we're really hoping that that's going to be a positive, but it definitely seems to be that way. And so that's got a real impact on how we deliver quick information to our staff. Bearing in mind we are, with Hillingdon, we are at several ambulance stations across London. We're 70 ambulance stations. It's very difficult to get information out to staff that they can read in a timely way. We use all our staff have iPads and it goes through on apps and whatnot, but it's still difficult at the start of shift. So actually having them come in once a week and have that 45-minute meeting with their supervisor and actually to ask questions on issues as well to deal with it is really, really giving us some real benefits there. The hospital withdrawal procedure, which we've also spoken about previously, which is a pan-London procedure, and that's where if we've been waiting for 45 minutes at a hospital, we will force a handover with the hospital staff. That's a very strong word, but that's what the process is. And just looking at December's figures for December 23, that's reduced down to just a 12-hour wait in total at that point at Hillingdon. And I would absolutely be remiss of me not to the appreciation of the staff at Hillingdon. This has been a very contentious process, and it's been very, very hard to manage both on the ambulance side and the hospital side. And it's been through the collaborative work, both at the senior manager level and the staff on the ground, that we've been able to do this. And it has been to patient benefit because, you know, having ambulances available in the community is absolutely critical. So that's just another positive there. We have introduced a feedback app called My Clinical App, and what that essentially allows us to do is it allows paramedics within safety measures and patient confidentiality processes, obviously, to be able to view what's happened to the patient they've taken into hospital. And that's really powerful for us because at the moment, or previously to us having this app, we would have to come in and ask that question, and sometimes it can get lost. And particularly with low acuity patients where we take it in, we're not entirely sure should they have gone in, should they have not gone in. Actually now we can see what treatment was done within reason at the hospital, and that's really going to hopefully empower our paramedics to make those decisions at the next time. Actually they might make them just being more well informed. So that's really helpful for their development. Just from an assurance viewpoint, both our tactical and operational commanders from the Hillingdon Group took part in the Council's annual resilience forum exercise in October. So just some assurance there that we're fully up to date with our resilience processes. And the contract with RAF paramedics that we have working within Hillingdon has been reviewed and updated, and just providing more assurance that it just gives us more clinicians in the community around Hillingdon, as well as working within different organisations. I think it's also just helpful to know within December we moved up to REAP 4, which is our highest level of extreme pressure. We have now come back down, thankfully, to REAP 3. But whilst we were doing that, and that was mainly due to an increase in respiratory illnesses due to the change in weather, and the 999 and 111 system was absolutely swamped during December. But it's really helpful to note that our response to Category 1 patients, which is our sickest and poorest patients, we've had a 7-second improvement on our figures. So while 7 seconds isn't a massive improvement, every second counts, obviously, with Category 1 patients. And certainly when you put in the factor of us being at REAP 4, the challenges with W45 and just the general issues that have been around with winter, that's a really positive for us. And I think that's probably all I want to pick up on, other than just we've seen some really healthy times and some really good positive processes.
Thank you. One of the good things about doing these reviews like twice a year is you get to see the progress going along. One of the things that interests me is actually the My Clinical Feedback app. And I wondered, you mentioned it briefly in your presentation, I mean, can you talk a bit more about how it's empowering your clinicians? I mean, is it, for example, enabling maybe more treatment to happen at scene? Is it able to make better decisions about where people are taken to? Or, you know, is there any sort of, do you have any feel for actually how much it's making being able you guys to be able to work smarter and better?
Yeah, so as you said that question, Chair, it actually reminded me of something else I also wanted to mention. When Derval was talking about EPR, and we've had the same over at Hillingdon, that is actually making that impact that makes that feedback app work, because us being able to pull, we've got the London Care Record, which is a NHSE process where all NHS organisations can feed information into, which we can then pull out of as organisations within reason, and that's what's enabling that to happen. So it's not a device that we would use on the scene with the patient. It's about that situation where what would we do with that patient, and empowering our paramedics to make those decisions, because obviously they're making those decisions independently out in the community. They do have access to senior clinicians to ask questions and have those conversations, but ordinarily those are autonomous decisions being made in the community. So understanding what the hospital did with that patient is really quite powerful for us, because we can then understand actually did they go off to have specialist treatment somewhere, were they transferred somewhere else, or were they discharged after a couple of hours after some monitoring, etc. So that's where the powerful bit is for us. So it will be impacting patient care quite considerably, but on the long-term process, and particularly with the low acuity patients.
Thank you. Does anybody else have any questions? Philip?
Yeah, a couple in one, using that one.
Of course, two questions. You're allowed two questions.
Okay, thank you. The first one relates, I suppose, to the volume of calls you must get, and one would think that a fair proportion of those are possibly not emergency calls that could perhaps be dealt with by other means. Presumably there is some means by which the London Ambulance Service filters out or perhaps signposts people, where necessary. I just wanted to understand a little bit how that works, if that's the case.
I could speak for hours on that subject, but I can absolutely brief it down to a couple of minutes. Yes, we do, is the short answer. So we have lots of layers within the 111 system and the 999 system. When people call, those calls are all put through a number of triage systems, and if it's appropriate, they will be directed to appropriate care, whether that be self-care or whether that be into pharmacies, appointments that we may have. So our 111 service has access to various GP appointments, etc. So there's lots of methods for us to do that. We also are developing senior clinicians in the control room, so that's the consultant level clinicians actually working in the control room to have those conversations, and that's really helpful for us, because not only are they having those conversations with the patients, they're also helping us to have those conversations with the services that they're trying to refer into, and that's been quite helpful for us, because consultant to consultant conversations generally work a lot better than a paramedic to conversation, sometimes depending on, particularly if it's a complex patient. That's really helping us, and our data in terms of what we can view for the patient is really powerful as well. So there is a universal care plan process, so where if a patient's got a complex need, the NHS in general, generally via the GP, can actually make a record of that patient's care. So when we're turning up on the face of it at 2 o'clock in the morning, we can actually see that there's a very intense and very well thought out care plan for this patient, and then rather than taking them to ED where they're going to be uncomfortable for several hours, actually we can hopefully instigate that care plan which is most appropriate for the patient, but also is supportive of not stressing the system because there's already a care plan in place.
That sounds very positive. My second question, if I may, given you're the one London-wide trust, I just wonder what opportunities there are perhaps to learn from different parts of the capital and share good practice, perhaps, to inform what you're doing. Is that something that takes place, generally speaking?
Definitely. So there is a lot of central committees and central groups that sit that the London Ambulance are part of. So we often have overlap between those groups, and then the regional groups within North West London also share. So there's lots of information that's being cross-pollinated, is a short answer. So we are making sure that we pick up best practice and making sure that what we don't have is isolated good practice in certain boroughs, that we're not then extrapolating that into all the other boroughs. We absolutely are doing that.
Thank you. June.
Thank you, Chairman. One of my questions was stolen by the chair. The other one is you said about the reduced waiting time. Is that picturing itself out, or is it going up? And the other question is, what is staff morale like? From the last report you gave us was very low. Is it up now, knowing that seeing that your the sickness rate is coming down?
Yeah. So in terms of morale, it feels better, and I think that's because our staff feel more informed and more engaged. As I said, that we're hoping that our staff survey results, that when they come out shortly, will bear fruit to that. So that's really, when I come back next time, hopefully I'll be able to share the results of that. But it does definitely feel that staff feel more supported. So that's probably answering that question in a positive. In terms of waiting times, January's been quite an interesting month for us. It's been balanced and not very pressured for parts of it, but then very pressured in other parts of it, which is kind of unusual. Normally a month is normally busy or not busy, but it's been very wavy for us, which is unusual. So it's difficult to answer that question certainly in the last 4 to 5 weeks. But generally speaking, it has been busy. But we think what we've been doing with the W45 process, the withdrawal process, is definitely helping us with managing that pressure.
Brilliant, thank you. Tony.
Thank you. Thank you for your report. Just following on from the Harefield and Brompton and Harefield question about staff retention, because I know it's been an issue in the past with the ambulance service about retaining staff, etc. How is it in Hillingdon? The levels good at the moment?
Yeah, levels are good in Hillingdon. We are doing quite a lot of work in investing in our staff, in terms of particularly with our junior supervisors and our lower managers, and that's paying dividends in that sense, because they're feeling supported. We are looking at how we can improve, very similar to what Derval was saying about improving at the mid-range, the career opportunities, to make sure that, and we've got lots of stuff coming that comes up. So with our 999 and 111 call centres, there's lots of opportunities for staff to go into there as well. So we are looking at how we can do that, but not do it as we're trying to do it because they're working within our single trust, albeit in different diverse fields. We're hoping that we'll have to do it, so we'll do like 3 months there, 6 months here. So actually, because a lot of our paramedics, generally speaking, still want to be on an ambulance, but they also want to expose themselves to other things. So we're hopefully looking to do that with some constructive contracts where they have to do 3 months here. A lot of our mental health cars, some of our specialist urgent community cars, that's how they work. So the paramedics will do 3 months on that specific resource with the extra trainers to do that, but then we'll also do the remainder of the year doing normal duties, and a lot of our staff seem to like that.
Thank you, that's interesting and good to hear. Just carrying on from the mental health side of things, working with the police weren't going to attend unless there was a threat to life for mental health. Is that happening, or is not happening?
So as in the process of right, I think it's right care, right place. If I've done that right, thank you. I often get that mixed up because we've got about 3 things with right something in. So I do apologise, I've got that wrong. So yes. So when the police formally pulled out of that in August, September, it was a challenge for us. Thankfully, there's been some top cover from NHS England, London, that wrote out to all of the acutes and the mental health teams, because we were getting more work because of that, because the police weren't going. We were getting calls to do welfare checks. So there has been some guidance that's been sent out to all of the mental health teams about that, just reiterating the process essentially of what the ambulance service will do and what the ambulance service won't do. We are acutely aware that we are in this void at the moment of services stepping up and changing their systems or improving their systems, or I'm probably using the wrong words there, being able to recruit to have their mobile teams that will be able to do these welfare checks. So we understand that that's something that's in track, so we're still supporting, and obviously we're not going to leave anybody adrift, as it were. So I hope that's answered that.
Thank you.
Thank you very much. Next, can we have Vanessa and Teresa from CNWL?
Thank you. So in 7 minutes we're going to do a double act.
You can have 10 because there's 2 of you.
That's fine, thank you. I thought we might go last as
Everyone
well.
else, don't bring 5 if you want 50 minutes. That's not going to work like that. But as everyone's been very good, 10.
Thank you. I was just going to speak quickly, to be honest. So I'm going to update on the kind of general, give a general update on Hillingdon, and then I'm going to hand to Teresa to give more of a detailed update on addictions, because she's the head of service for addictions, which includes covering Hillingdon. So if I just start with kind of things that are still going well from the last time I updated. So we still are doing really well on our 2-hour response time from our rapid response teams. That's our physical health team, supporting people who have, I guess, in crisis and need support. We're still doing, we still have our crisis house, so it's called the Retreat. So we do have an average occupancy there of 70%. It fluctuates actually in terms of the occupancy, depending on whether it's needed by people. Actually, with a really good average length of stay of 10 days, which actually is what we set out to do, and didn't want people staying there for a huge length of time. What I will say is we're doing an evaluation now because the funding we have ends at the end of April, and we're keen to work with ICB colleagues and our Hillingdon system partners to continue with the crisis house, because we've actually seen some really lovely stories, or heard some really lovely stories from people who would have otherwise either gone to A&E or maybe been an inpatient in a mental health hospital, but they've used the retreat. So we're hopeful of that. And we continue to meet our targets in terms of seeing children and young people within the target that's set. So what we've seen is we now only have, so whilst I say these numbers, I still don't think it's right. We'd like to say 0 children waiting, but we now only have 49 children waiting for their first appointment, which has come down from 200, which was at the back end of 2022, and we have, so that's a 76% reduction, and we've got 167 children waiting after their assessment for treatment, which is a 49% reduction. So we still know that's not right, and we want to continue on that journey. We also have had agreed the new wave of funding for the mental health in schools teams. So we are a bit behind, we're not behind the curve. It felt like we weren't first on the list to get the waves of funding from NHS England and Hillingdon. We've now got that coming through in September 2024, so we can make sure that we have mental health support in all schools in Hillingdon. So what is new? I think last time I was here, we said we were talking about the IAPT target not quite reaching where it needed to, and I was talking about the initiatives we've put in. That is now meeting the target, I'm pleased to say. Since last time, we have set up, it's a North West London facility, but set up an eating disorders day hospital for children. It's actually for ages 13 to 18. So it's a new model, an innovative model that takes children as well as their families. And this is for children who are struggling with their eating, but really for children who are maybe, I'll say, stranded, but getting treatment, receiving treatment in an acute hospital. So they're probably so poorly that they're not attending school. They will go to this day hospital with their family and any siblings as well to actually get treatment and support in this day hospital. And it's a 6-week intensive support programme. We opened that in November, and we have got Imperial College doing some evaluation with us on that when the time is right over the next year. What else is new? We've embarked on integrating our palliative care teams across Hillingdon, so we are a part of that, and it's probably in Keith's report, so I don't want to steal his thunder, but we are all, bless you. Bless you. So we're all a part of that, but that's going to be kind of no wrong front door, so really listening to what our patients and their families as part of the palliative care pathway have said to us. I also need to update on the wellbeing bus. Just very briefly today to say that is coming, the pilot has come to an end. There has been a few hiccups, which include the bus not being available to us for us to use. So the evaluation, once it's written, we are just trying to set up a date for early February with the residents of Heathrow villages so that they are actually integral and they actually are helping us lead what it says in that evaluation, and then we're not telling them what it says. I shall hand over to Teresa.
Thank you, Vanessa. Thank you very much for having me today to give a bit of an update regarding the addiction services in Hillingdon. I'm pleased to say I've got a number of really quite exciting things to share with you hopefully today. One of them is we really are doing incredibly well on a number of our metrics, if you like, which demonstrate some of the quality of work we're doing. I don't know how much you know, but numbers in treatment has been a real focus for OHID, which has given us a number of additional grant money, which is dependent on 2 particular areas. One is the number of people that we get through the door, and the second really important thing is how we engage with people who are leaving prison. So I can say Hillingdon has absolutely smashed it in terms of we're the 2nd highest borough in London in terms of new people coming through the door, which might sound like a bad thing on one thing that people are coming through the door, but it means that it's a good thing because people are coming through the door. They're not waiting, so our waiting lists are really good. They're staying, so when they come in they're retained, and when they're leaving they're doing really, really well. So we're in the top quartile for successful completions. So those are some things we're really pleased about. And so the other thing I wanted to say, some of the things we're proud of and concerned about, is the physical health care of some of our clients. People are arriving needing quite a lot of, have got quite a lot of number of healthcare needs. Some of the things that we've set up have included kind of fibre scans to look at people's livers, spirometry to check people's lungs, etc., for kind of trying to early detect where there might be problems going wrong. The other exciting thing is that we have achieved what's called hepatitis C microelimination, which means we've been able to test and treat and cure all of our population within Hillingdon, which is quite a major achievement, and it's ahead of the NHS England target of 2025. So we've been a major contributor to that. So we're quite proud of that. I'd say, some of the challenges I'd say would be around stigma. I think it's often there's some parts of our communities that are not coming forward for treatment that we would like to see. I don't want to call it hard to reach populations, rather than see it as our services need to adapt and go to different lengths and different means. So we've got some thoughts and ideas about that. And overall, I think, it's just some of the language that we use. We're worried about middle-aged women drinking too much and not coming forward for treatment. And there's the hospitals, obviously, and, other areas of the system putting, pressure on those. So we've been, I should have said, we've been working very closely with hepatology colleagues to be able to achieve the microelimination. And that is a roundup.
Thank you very much. I know it's very difficult to try and condense all the work you need to do, you're doing. So first of all, I'll make 2 points. Firstly, about the Harefield bus. Obviously, certain areas in our borough don't get as good. Sorry.
Heathrow Villages.
Yes. Sorry, Harefield as well. Hairefield's on my brain because partly, and you'll understand why I said Harefield in a second. But thank you for that. There isn't a Harefield bus. There might be a Harefield bus, we don't know about it. But the Heathrow Villages bus. So obviously there are certain parts of Heathrow Villages aren't getting the coverage they deserve. The bus was an idea to try and do something different. Myself, Sital and Philip were going to go down last week and see it, but we couldn't because the bus had broken down, and apparently it was not going to be ready again until the end of the trial, which sort of suggests maybe the trial hasn't been overly successful. But ultimately, trials are good things. I'm not even if it's not successful, we'll find out when the report comes in, it's worth trying things. But what I was going to suggest, and I was going to suggest to the committee in the work plan as well, when we discuss it in the meeting, is we have our next meeting, I think, towards the end of February. I'm looking at Nikki. And I think it'd be very useful then if we cover this item more in depth, but also at the same time bring in Harefield, because the coverage, the health coverage, especially of primary care in our rural parts of our borough, we're an interesting borough because of that, I think is connected. So I was going to sort of suggest that, and I, Keith, you're involved as well, so you're nodding. So
yes, that's fine.
Yeah.
It sounds sensible.
Okay, brilliant, fantastic. And the question, I've got lots of questions, but I'll just ask one. So this sort of scheme about mental health professionals in schools, and so every school has coverage. Can you explain a bit more what that actually means, and potentially what the positives of that for the system as a whole are?
Yes, so we do already have so it's a mental health clinician, so might be a nurse, but it might be another professional who is linked to a school, so they might link in with, so schools already have obviously SEND teams and they have wellbeing departments in their schools, so the mental health clinicians, so we do already have some coverage in some schools, and I can get the details for you in terms of which schools. We do have that already, we just want to expand it so it covers all schools, and they will pick up, so this is really to try and focus on the preventative side of things, so that children and young people, we don't wait for something to be so wrong that they're ending up actually having to be in a formal CAMHS assessment. Actually, we'd rather spend time and have a clinician working with them and potentially their family while they're in school, if they need some lower level counselling or lower level support, or they might just need some advice, or the school might need some advice. So that's really what the focus is.
So it'd be very interesting to see how that works in practice, because ideally, obviously, we try and capture issues at an earlier stage, which should be beneficial to everyone. Okay, fantastic. June.
Thank you, Chairman. I've got so many questions, but I'm only allowed two. The first one
I'm sure they'll be the two most excellent
You have one of mine if you want.
Back to the bus service. At our residents' meeting over the weekend, Saturday gone, they were very, very unhappy in regards to the bus service and the supply of and what's happening. In regards to cancelling the bus, the services at short notice, not giving them any notice about it. But then, surely you were aware that the bus that is being used was not going to stand up to what it really is, because it's giving the service, it's looking for people to say what it wants, but at the same time, there is nothing there really in having the service to run the way it should run. They were told there was no driver, the bus was broken, and at the same time, nothing to replace it. So disappointment all around in regards to that. And then you said the service will come to an end. What will replace it when it comes to an end? And how are you going to engage with the community to enable that, to look at what other prospect there is? I know, Nick, you said you want Harefield to be involved in it. It would be good if we can get different areas, but this was a pilot program that was supposed to deliver and show a way forward, and obviously it hasn't done that because it mucked up in the middle of it. So can you tell me and tell our residents what in Heathrow villages, because I know they're watching now, what it is you're going to do to enable that to happen?
Yeah, and that's absolutely fair question, Councillor, because that's exactly what we've heard from our residents of Heathrow villages, and absolutely, I really heard that. So in terms of the bus, and it's unfortunate that I feel like our local authority colleagues aren't here to talk about that, but in terms of the bus, this was a Hillingdon system offer. We in CNWL don't own any buses. We asked the local authority if they would provide a bus. So the bus and the driver came from the local authority, and it's unfortunate that there were a number of occasions that maybe the notice we got about the bus not being available and then breaking down for the last couple of occasions was very short notice. And I can assure you that as soon as we found out, we let the residents know. But it was short notice, it was late notice, and so I can only apologise to the residents that was short notice. And I assume that we will be making sure that as part of the evaluation that whatever bus we put in place for anything in the future does need to be something that's quite robust and is working, because I was there certainly on one occasion when it wasn't satisfactory, the bus that we had provided. So that's kind of number one in terms of the transport, and we do need to make sure that we have got the right the right equipment, as you would do if you were doing anything like this. And the second part of your question, that will all come out in the evaluation. So whilst we said that we would do a pilot and there would be an end date to the pilot, we're not then saying there'll be an evaluation and we won't do anything. We need to do the evaluation to then determine, well, what worked well and what didn't work well. Off the top of my head, there were some weeks that were better than others, and I appreciate it was a mixed bag. What I believe we were trying to go for was offering a variety of different things so we could get the best out of the pilot to put forward to the evaluation, so that we could then determine what it was we needed on the bus.
So Keith just wants to come in, because Keith was involved in this as well in terms of answering your question, June.
Thank you, Chair, and thank you for the question, Councillor. If I may challenge and back, the problem is it is historically health has told the villages what it can have, and what we're trying to do is ask the villages what they want, and the reason why we're doing the evaluation, we're doing it, is we want to speak to the residents first and see what they would like in the villages, and then we'll craft the outcome based upon that. And then I think we can have a discussion, Chair, I think at the end of February. But I think it's really important that we listen to what the residents want. What we accept, I think what health completely accepts, is that there are challenges accessing health services in those villages which are legitimate challenge, and we need to recognise that, I think, as health, and come up with solutions with the residents that meet their needs. And I think that's what we're desperately trying to do. The risk for health is either we tell people what they can have, and then they'll say, well, actually, you're not listening to us. We don't want that. We want this. So I think we're trying to do it differently this time. So I would just ask councillors just to bear with us while we engage with the residents, and then try, if we can, and come up with a solution that we can all get behind, residents as well as providers of health and the local authority, I may say, as well.
I can hear some residents in my ear saying, well, we've told you lots and lots of times over a massive period of time, and you know, the situation is still the situation. I mean, I'm happy when we have our February meeting to talk about this in more detail, because I realise the pilot has sort of come to an end and you do have to go through the process. Obviously, our impression of the pilot's not very good from what we've heard from residents, and also the fact when we wanted to go down and see the bus, we couldn't see the bus. But a more depth discussion in February about how we could try and resolve this issue, I think will be good. June, did you have another question?
Yes, I do. In regards to the retreat, in your presentation here, I'm only now seeing it, and I just scanned the report here. Under the retreat, you said fully it's funding and underspending previous year, yeah? So there's a current understanding, you said. However, there is no current underspent, as therefore fundings would need to be sought to continue post-April, and a proposal has been made. This will need to be considered in cost pressure, and the system is unclear at this point whether or not this will be successful. So if it's not successful, what's going to happen with that retreat? Because that's something that residents really depend upon, especially with the cafe, for those who are either in crisis or is just coming into the midst of crisis. And the cafe normally somewhere where they can go to, or signposts to, for them to get some kind of help, seek some help and support before the crisis get out of hand.
Yep, so this is only in relation to the retreat. So the coves we are fully funded for, and that will remain. And I guess I did update last time, but the Coves Cafe moved to be very close to and right next to the crisis house. So that's been a benefit. You're quite right. In terms of the retreat, we in CNWL managed to find some money to be able to, because we heard from residents, we spoke to our patients, we knew that a crisis house was something that was needed, so we were able to use some money we had within the trust to be able to fund that. We can't do that. We can't continue to do that because we don't have any additional money to pay for the retreat. So what we've done, as we would do with everything, again, the retreat has probably been open for 18 months, so we wanted to do an evaluation to show the effectiveness of it. We have put a business case into the ICB so that it can be funded appropriately.
Thank you. Philip.
Thank you. Here are my two questions then. The first relates to CAMHS, which we're looking at later on in the agenda. You talk about the number of children waiting for treatment to start. My question, I suppose, is around what's going on underneath that in terms of preventative interim type support. You talked about that being delivered in partnership. Are you able to say anything about the extent to which children in that situation, where appropriate, are able to access this support, or can you comment on that at all, or don't you know?
Yes, I can do. So we have got, and I've got a list, I think it's in one of the reports, I've got a list. So we did actually fund some third sector organisations to support with children and young people who are waiting. So we've got a range of schemes that have been funded with, so Arts for Life, P3, Hillingdon Autism Care Support Centre for ADHD and Autism, and Brentford Football Club. So all of those organisations are organisations that young people who are either waiting for assessment or waiting for treatment can be referred to support.
So, a quick supplementary, if I may. So, would I be overstating things then to say that people, children in that situation, have access to those services and they can readily access them if they need them? Would that be overstating things, or would that be?
That's correct.
That would be
okay.
That would be
thank
correct.
you.
Okay. My second question is around alcohol admissions to hospital relating to the ARCH service. Certainly for some years, Hillingdon was a bit of an outlier in terms of alcohol-related admissions to the hospital. I wondered to what extent that is still the case, whether you can comment on that, and how actually ARCH are working with the hospital, what that interface is like in terms of repeat admissions, and what we're learning from that to try and move things forward, please.
As you say, the hospital-related admissions for alcohol, is it on?
Yeah, it's on. Yeah.
Is a concern. We have had some. We've got one vacancy currently at the moment, and at the moment we are in the process of seeking to appoint somebody into that role. So that has had a bit of an impact on the hospital. So, good question. We work where we also have a number of the team, the nurses, the nurse specialists within the team who visit the hospital where we don't have a permanent post in place. And we're confident that we're going to get somebody in place very soon to fill that gap.
Okay, I mean, if I may I be really pushed by that. Okay, thank you for that. I mean, it has been quite a long-standing problem. Yeah. I mean, whether or not that in itself is enough to deal with things, I guess we'll have to wait and see, won't we, really? But no, thank you for that. Thank you.
Thank you.
Oh, Lisa, yeah.
Thank you. I just have one question. It's in relation to CAMHS. So one of the things that came up when we were going through the review was about the number of referrals that were rejected, and I just wondered whether that had improved and there were less, we're seeing less, or whether that...
I would probably have to find that out for you in terms of numbers that are now no longer rejected.
Yeah, that's a really good question. So could you let Nikki know as well, so she can give that to the rest of the committee? Thank you.
Yeah, of course.
So, okay, June, you can position your mic on. You promised me this is the last one and it's quick, so I'm going to break this.
It's just a great thank you to ARCH, because we were invited to the centre when they had the party, and it's amazing the amount of services they have under one roof to help people with drugs and alcohol assistance and alcohol abuse. It would be, what we find is that I don't think the service is really shared out enough, either in the NHS or community groups, that this service is available, and whoever, any of the residents who actually access this service, they don't have to go to different signposts at different areas or community areas to get stuff done. It's all done under one roof, and I just want to say thank you very much for inviting us, because we didn't know about it, and it was great to see the sort of work that you're doing there.
Thank you very much, June, and also Tony, for attending. It was really, really good to have you there, and yeah, we had a whole day showcasing all the different types of things we do, which is a huge number of things, from rough sleepers going out and looking after the homeless to taking people's health very seriously and doing full assessments, to counselling and day programmes. So thank you very much for coming and for your interest on the day. It was good to host you. Thank you.
No, thank you. Always good to hear a positive endorsement of a service that you see. So, sit on.
Thank you. I've just got a couple of statements and two questions, if it's possible. First of all, I just want to congratulate you on the things that are going well, because it's always easy to focus and answer questions on the things that are not. So it's really good to see that even if this is something like the retreat, it's been so successful that there is a need for it to carry on. It's not great that there is a need for it to carry on, but obviously there is, and it should be funded. And also on ARCH for being the second highest in London is absolutely fantastic in what it's doing for its clients as well. I just wanted to ask in this, because of just things that have been purported in news, and because we talked about women and drinking, but there seems to be, I know especially in the housing sector, a lot of men in their 30s who are seen as with depression and addictions as well, and I just wondered if they were coming up into the system as well, or is the focus mainly on women?
I wouldn't say that the focus is on women. I think this is just probably an untapped area where generally in our services we see a lot more men coming forward than women, and typically it's about a 70-30 split of men to women. So women are more underrepresented. So I'd say yes, and the increase in numbers of people coming through for alcohol is a steady rise. I'd have to get back to you about the exact demographic of whether we've seen those men. But yes, it's quite typical. I mean, it often tends to take about 7 to 9 years for someone with a drug or alcohol problem to actually enter treatment. So our aim is to always intervene at the earliest possible opportunity. So thank you for asking.
Thank you. And my other question, I welcome, as you know already from how much I've spoken about mental health, that there will be a funded clinician or funded nurse in every school in Hillingdon. I don't know if this is a permanent structure because some schools have it, but they go around different schools on different days, so I don't know if that's going to be a permanent thing or not. But I just wanted to something that I'd heard the other day, where a teenager today sees the same amount of trauma in one day as an average person 25 years ago would see in their whole lifetime, and that is through social media and through just news, like daily encounters, whatever it is, and that's quite a significant demand on any teenage child. So I just would like to know how permanent that fixture for a mental health person in a school is, because I know in my daughter's school they've got a roving person one day a fortnight, which has to deal with quite a lot of cases, and it's really tough for them as well.
Yeah, absolutely. And because we've been slower in getting the funding, so obviously there's been a programme across from NHS England in terms of which boroughs are getting the funding, and we have tried to fight for the funding to come through. So once that money comes through in September of this year, I mean, from my perspective, I would want to start making sure the service starts planning and recruiting ahead of that, so that we're ready to get going as soon as the money comes. Otherwise it will be after Christmas and then into 2025. So the plan is that is a permanent structure. Yeah.
We definitely want to know more about it once it's up and running in the coverage, because Mrs. Hill makes a very good point. What is that actual coverage? And that stat is quite scary, actually. So, thank you. Adam.
Thank you, Chair. You'll be relieved to know I've only got one question. So it's in the run-up to Christmas, there was a media narrative around the increase in the sale of low or no alcoholic drinks, and particularly sort of a generational shift that Gen Z are much less likely to go out and drink to the volume that the previous generations have. Have you seen that trickle through in terms of the sort of age demographic of those seeking support for addiction? So, for those that are Gen Z, say up to sort of 28 years old now, are less coming through? Do we see in society that there's less addicted to alcohol than there was, say, when millennials were at a similar age? So it's quite a niche question.
It's quite a niche question. It's a really good question, and I'd say definitely what you're saying is conversations that we're having all the time, and also amongst ourselves, is that the younger generation is not drinking in any way like some of the older ones have done. So obviously we're dealing with adult services, and I think it's probably a little bit too early to tell of how that's going to impact on the kind of longer term treatment. But we will soon start to tell, but I don't have any evidence for you now how that's looking, but we'll be keeping a close eye on it too. Okay.
There were reports of rising drinking during the pandemic, obviously, though, as well, wasn't there? So, that'll be interesting. What have we got next? Tony.
Thank you, Chair. I was sorry to see about the retreats there, and I hope that you're sharing the outcomes, the good outcomes with the ICB. And how hopeful are you actually getting the funding? Because obviously the end of April is not that far away, and people wouldn't want to know if the service is still going to be there.
Obviously, I remain really optimistic, and I think our story and our evaluation will be able to prove, with both the kind of qualitative but also quantitative side of things, we'll be able to prove that it's been a huge success. The other thing that we're doing is we're going to try and quantify with that data how much might be saved in terms of both mental health beds, but also people who might have gone to A&E. So we are working with colleagues across the system to see if we can try and quantify that to prove our argument. And I think actually that's something I know my partners and in Hillingdon will join me in trying to get that money.
That's good. You're talking my language, so it's good to hear. And if we can offer any support in any way, feel free to take an endorsement from us.
Richard. Sorry, Tony. I just because that question sort of could be relevant to Richard as well. So, I mean, Richard, do you want to comment on it, or are you able to comment on it at the moment? Because I think the retreat is very positive. I agree with Tony. So it'd be really good if it could continue.
So I absolutely share the committee's support for the service. I think it's been a long overdue and a really innovative service for Hillingdon. And I think the figures that it's showing now for diversion from A&E speak for themselves. Vanessa and I were talking about this matter this very morning, and I am certainly pushing the powers that be to take that decision as quickly as they can. I think the data, particularly on occupancy and maximising the take-up of the retreat, is really important, and I'm sure that Vanessa has got the figures that we can demonstrate how well that's used and how well it's meeting particular target groups. It's traditionally taken a more adult population, and we were also talking this morning about whether there were ways safely of offering a service for younger clients as well, maybe late teenagers rather than younger. So certainly as far as Hillingdon Borough team is concerned, it's a very important part of the service, and we will certainly push others in the ICB to share our enthusiasm for it.
I mean, if it helps, I mean, obviously as a committee we think it's a very good service and we'd like it to continue, and I think that's everyone's nodding. So I don't know if that helps or not, but yeah, obviously good luck, and obviously we'll look forward to the outcome of that. Tony, I cut you off. Did you have something else you wanted to ask?
Yeah, just very quickly, just a statement really. Just want to echo what June said about the arch. I found it a very uplifting and encouraging day, despite the seriousness of the issues that are being dealt with there. And I came out of there thinking, well, there's something really positive is happening, and there were so many good stories there to hear. And I encourage anybody, if they do another event, that many people as possible should attend and meet the staff there. A very good bunch of people.
Thank you, Tony, and well done on the open day and the work you're doing. So, excellent. Okay, nice to end that section on a positive note. So, Vanessa and Teresa, thank you very much. You can leave if you wish to. So, but thank you very much for coming to see us. Patricia, would you like to go next for Hillingdon Hospital?
I think I have a presentation. So, Nikki, I'm not sure. Perhaps if you know what to do. Let's see if it'll. It's got a blue light.
I always love this one.
I know. I'm assuming it's the up and down button.
It is, and it's on the
This is why I'm not scared about AI taking over the world. Seriously.
I mean, I'm very happy to just talk to the slides if that. Yeah. So I'll make a start and then I can come back to this. So this is the same format as the presentation I did when we were here in September. I'm not intending to go through it. It's in here in part as a reminder to committee members about where we are in terms of delivering our business plan. I wanted just to pull out one or two key issues, one particularly that's come up as part of a question that I got about a year ago, but there have also been some queries from the public about it. So starting off with quality, absolute focus for the Trust on improving our quality and improving patient experience. you can see in the slide that we've done some work around the language translation services. It's something that comes up quite often from patients about whether or not we can communicate with them, and particularly important given the demographic of our local population. So we're delighted that actually we've now got 2 service providers and they can provide a 24/7 service. I think it's important to say that we do have issues with patient experience at the moment, and I'll come on to that in terms of our emergency performance at the moment, and that's clear that came out of some of the Health Watch feedback as well. So I can see in our complaints and just in general my awareness of the amount of time that patients are having to wait in ED, that is not a great patient experience at the moment. And although we've actually had some really good success with handover times with London Ambulance, that means that we have patients who are then in the department. So they're much, much better. They're not sitting in an ambulance or not sitting at home, but it does mean that at the moment we are finding that our ED is often very overcrowded, and we are having difficulty getting then the flow through into the hospital. And I say that in the context of actually some really, really good partnership working with HHCP and HHCP, which is the borough, CNWL and other partners, about managing the flow of discharge. So certainly since November, it has felt very pressurised in our emergency pathway. So I just wanted to point that out, and I'll come back to that. We are seeing a couple of things. So on our elective performance, actually we are being very successful in reducing our elective and diagnostic backlogs. So that is really positive, and although we have had problems with having to cancel patients as a result of industrial action, actually we are well ahead of where we intended to be, and that's on top of a new patient record system being introduced, where we had actually planned to reduce activity during that period. So actually that is really positive, and we are actually one of the best performing trusts in terms of 78-week plus waiters, in that at the end of December, so I can't remember what's in here, I think it was 1 patient at the end of November, we had 4 at the end of December, but we are absolutely clear that we intend to reduce the number of patients waiting over 78 weeks and also the number of patients waiting over 65 weeks, and that is a big change compared to 2 or 3 years ago, so it's really positive. And then probably in terms of quality, the only other thing I wanted to say very quickly is that the Care Quality Commission is introducing a new way of inspecting from January. So we know that they will come and inspect Mount Vernon Hospital because we haven't been inspected in the last 5 years, and they have a requirement they have to do that before they start the new regime. And we're expecting them probably in this quarter. And they will be starting a much more targeted regime of inspections from now really, and in fact I'm joining a presentation tomorrow from our local inspector to understand what that regime will look like, but it'll be more targeted, only look at certain standards, but we understand that there will be an opportunity to change your rating much more quickly, because if they come and look at a particular service, depending on how you perform, you can ask them to come back once you've resolved the issues, whereas at the moment it tends to be you're in a long queue and at some stage we'll get back to you. So I think that will be really positive. In terms of quality, I just wanted to take the committee to, the next area, which is there were some questions about the provision of single-sex accommodation. The details in here, so I'm not going to go through it in a lot of detail, but it is really important, and this is an NHS standard, that patients who are admitted to hospital must be afforded appropriate privacy and dignity, because they're most vulnerable when they're in hospital. There is clear guidance on single-sex accommodation, and I direct members of the committee to our website, where we actually have a statement about the management of single-sex accommodation. There are very rare occasions where you have to mix sexes, so outside the guidance. There may be issues where there's a flow issue or whatever. Actually, we have very, very low issues of that, and in the time I've been in Hillingdon, it's 1 or 2. And in those cases, we absolutely follow the guidance in that we let patients know that that's the case, and we take care to make sure that their privacy is safeguarded as much as possible, and we resolve that issue as much as possible. And I know from some data elsewhere in London that our levels are very low comparatively. So, and that's within the context of some quite outdated accommodation, which makes it quite difficult. So, the other question that was asked was, what do we mean by single-sex accommodation? Again, it's essentially areas where people sleep overnight when they have been admitted. So it does not include ED, does not include critical care, apart from in specific, with specific issues. And actually, the layout of our new critical care unit means that there are 2-bedded bays or single rooms, and actually it's much, much easier to be compliant with single-sex accommodation than it used to be in our old critical care unit, where it was rows of beds, and therefore it was much more difficult. Once someone needed to move out of critical care unit, you then have to move them to a single-sex accommodation, and actually we can hold patients for longer in critical care if necessary, because we can maintain that single sex. So I wanted to bring back the information to the committee and to hopefully assure the committee that we are actually managing that situation very well. In terms of the rest of the presentation, I'm not going to say very much around the people agenda, other than we think it's very important. In terms of emergency performance, you have some graphs here. I think the important thing I really want to point out is that our standard of patients being seen within the urgent and emergency care pathway within 4 hours is dropping, not going up, and that is not a good position to be in. We are kind of in the pack in London, but I have to say being in the pack in London is not a good place to be. And we are certainly seeing some significant deterioration, particularly in those patients who are most needing ED intervention. That performance has dropped. We do have an action plan to improve that, but it is proving to be difficult to crack that at the moment. If I move on to finance, the important thing really just to say is, and I don't think I knew this when I was here the last time, but we have for the last 2 years been in what is known as NOF4, so National Oversight Framework 4. It used to be called Special Measures, and we've moved from NOF4 to NOF3. And actually all of our enforcement actions associated with that have now been lifted. So that is a really positive place to be. And I think I look to Keith and others, but you know, that feels much more positive in terms of our partnership in Hillingdon. And then just finally, in terms of our strategic programmes, like Harefield, we implemented our electronic patient record system. We're using Cerner. Harefield is on Epic. There is a little bit of competition at the moment about who's had the biggest implementation. So we are on what's known as a single instance of Cerner across North West London. So if you're a patient in North West London now and you're seen at any of our acute hospitals, your record could be seen wherever you are, which is a really positive position to be in. Actually, we were delighted. We have learned a lot from the implementation at Imperial, Chell West and London North West. So the implementation at Hillingdon in general has been very smooth. Our activity is pretty much back to where it was before implementation. And what we're now really doing is working through the kind of nitty-gritty things of some of our clinic. I think probably outpatients is the area where we've got most work to do in terms of getting our clinic profiles back to where they need to be and making sure that staff are happy using the system. But generally staff have engaged with it very well. And then the final thing I wanted to say was delighted that we got full planning permission for the new hospital development, and alongside that we are really getting on with doing the decant and enable work so that we can clear the site ready for the new hospital build. And I am pleased to say that as I came out this evening, one of our old annex wards has a big notice that says closed for demolition. So that's a really positive place to be. So that's all I really wanted to highlight.
Thank you very much. I think I think it's very good news that the rollout of the new patient record programme was not very interesting, because obviously rolling out these programmes you want them to be not very interesting. I mean, I was quite amazed when I found out about the programme that it wasn't possible to access different medical records across different parts of London for people, so hopefully that will be very positive actually and help people get their treatment quicker. I want to ask a question about staff engagement, and in at the back of your slide you sort of say internal focus on staff engagement and making the trust a great place to work, because that we've heard a bit about the recruitment challenges and you know what really makes places of people, I think anyway, and so you know and previous sort of staff surveys haven't been the best always. So can you tell us about any progress you're making in that area, and also, I mean, what are you going to do to try and make Hillingdon Hospital a great place to work?
So I think one of the things that is really frustrating about Hillingdon is if you talk to staff, they will say it's a great place to work, and it's like being in a family, although I have to say probably our mental health colleagues say some families are quite dysfunctional, but people will say it's a great place to work. And in fact I met with a senior member of staff today whose sister works there, 3 of her cousins work there. You know, it is a place where local people work. And if you say to people, I love working here, it's a great place to work, what comes through in our staff survey, and we've seen a deterioration, although it's flattened out now, over the last few years, is staff not recommending it as a place to work and not recommending it as a place for their friends and family to be treated. So there's something that doesn't quite add up. And what we've been trying to do over the last couple of years as we've come through COVID is to try to do a number of things. First of all, to develop our staff networks so that we've got more sources of information from different groups of staff about what it is that is bothering them. We really actively pushed our staff survey this year. So we had an 8% increase in the number of staff who filled in the survey, and we've had a first cut of the survey, but we need to get the next cut before we can publish that. But it's on a first cut, it's showing some small improvements, which is encouraging. It feels like it's some green shoots. And then what we are actively doing is looking at a couple of areas that seem to come through as themes from a number of different surveys we've done. So some concerns about bullying and harassment, and some concerns about opportunities for personal development and promotion. And those are some of the areas that we're really focusing on in terms of how we recruit and retain, how we improve the skills development offering for our staff, and really cracking down on what it is that staff feel is an issue in terms of bullying and harassment. But I think we're starting to see something a bit more positive with that. So those are some of the things. And we're holding our own in terms of, so our vacancy rate has dropped. We've done, like others, quite a lot of international recruitment, and that's very encouraging. And our turnover is about 12%. I'd probably like it to be slightly less than that. But one of the things that we have agreed is that we are going to start recruiting to turnover instead of recruiting to vacancies, so that we start to try and we don't have gaps. So that's the plan.
Thank you. Philip.
Thank you. Similar question to the one I posed to Clinton of the ambulance service earlier on. You've acknowledged the issue with A&E wait times, and I know we've discussed this in the past. I just wonder, to what extent, I mean, obviously there will always be genuine emergencies, but I suppose equally there are those who see A&E as the fallback. It's the place of last resort. It's always open kind of thing, and I wonder to what extent there are cases that approach A&E in that sort of situation where, for want of better advice, support, signposting, perhaps they might not be there in the first place, that might perhaps alleviate some of the challenge. Is that a big issue? Is it negligible in the scheme of things? And if it is an issue, I just wonder how that's being worked upon in the context of the wider ICP. Thank you.
So we have, over a period of time, and this is across the NHS, we have changed the front door to A&E. So we have the Urgent Treatment Centre, which is a GP and emergency nurse practitioner service. So you don't see a hospital doctor there, and the idea was that patients weren't able to see their GP, or they might need something that was a more enhanced GP service, and urgent treatment centres were set up for that purpose. So we see about 50% of the patients who present at Hillingdon come through the urgent treatment centre and don't ever get to ED. They are discharged back home. That service also signposts back to general practice. They signpost to other community services, and they're increasingly signposting to the hubs that we're setting up within Hillingdon as part of Hillingdon Healthcare Partners. We have the walk-in centre at Mount Vernon. That's a bookable service, although we are talking about whether we should consider opening up again to more walk-in. And they do both booked service and they do telephone advice. That hasn't picked up to the extent that we thought it might in terms of what used to happen before COVID, although we have picked up recently that we do much more telephone advice, so it might be we're just not recording that. So and then the other thing is, in terms of releasing pressure in the emergency department, we now also have a lot of patients, and the ambulance service support this very well, where patients will come in and actually they don't need to be seen in the emergency department. They can go to our same-day emergency care, be that surgery or medical. So it's trying to get people to the right place as quickly as possible. Our biggest issue, or one of our biggest issues at the moment is, I think I've said this before, the design of the emergency department in Hillingdon is not great. All the evidence says you have one big space and you use it in a very flexible way. We will get that once we have a new hospital. At the moment we've lots of different areas, and when we get lots of people coming through at the same sort of time, we just physically don't have enough space to assess patients. That's one of our biggest problems. But I think in terms of routing people away from the emergency department, actually we've got all the right things in place.
Adam.
Thank you, Chairman. You answered my first question, which was just around an update on the hospital. I was on the committee that approved it coming up for a year ago now, I think. We perhaps need a committee off-site for the first demolition when that comes around.
Does that mean we get to wear hard hats and yellow vests and have pictures?
I'm sure there's a long line of people waiting to press the button. No, my other question probably is more for yourself, but also the broader community partners. Is just something I have personal experience of with my grandparents in a different borough, different part of London, as to, I suppose it's a build on the paramedics needing to offload patients into a hospital. How much are hospitals having, and Hillingdon specifically, having to hold patients that need to go into the social care system, but for whatever reason are not? And I'm thinking particularly this time of year with the elderly, but I guess it's not exclusively that. Are we very good at that? Have we been in the past sort of year, or is it an acute problem?
So actually, if you look at this paper, there's actually some really good evidence in it. So this is from Hillingdon Health and Care Partners, that actually talks about the level of what we call delayed discharges. Is not a good word, and actually our levels are relatively low. That doesn't mean we've not got more to do. So we probably have about 30 patients in hospital at any one time that don't meet the criteria to reside and would be better cared for in another environment. But actually we have really good working relationships with Hillingdon Social Services, with our local health and care partners. We do a lot of work with our community partners about keeping people in their home environments, putting packages of care in place. But with all of these things, there is a cost associated with it, be it that you're a self-funder or you're being funded by social care, and getting those packages in place can take a bit of time. So we do have patients who are with us for longer than they potentially should be, and the longer they stay in hospital, the evidence is there that if they're confused, they become more confused. They may pick up infections in hospital, so you think they're ready for discharge and then something else happens and they get delayed. And that can be quite confusing for families.
And so just you said around 30 on average. what is that as a percentage of the total number of beds at Hillingdon? Is that a considerable number?
About
I mean, it's obviously, from what you say, it's on the good
like
side
that,
of where other hospitals would be at.
So we are probably the best in North West London in terms of the percentage. We have this dreadful phrase, we always do it in NHS, called patients without criteria to reside. Yeah? And bluntly, that means patients who are well enough to be at home, wherever home is for. So as a percentage in heads of population, we probably have the lowest in North West London. We've worked really hard at that for quite some time. I think the challenge for us is because obviously around 75-80% of Hillingdon's inpatient at any one time are Hillingdon residents, but the other 20% are from other boroughs, and this is not me offloading issues, but we tend to have more problems with the patients of other boroughs getting those out, and that kind of factor 2 weeks ago. I mean, there were more people from other boroughs waiting than actually there were Hillingdon patients. So we're trying to balance that all the time, but we work. I mean, I must spend half my weeks poring over discharge metrics, of which there are many, but we work really hard. And I would say this if the ICB corporate team were here, they would recognise that we, in terms of discharge, we do better than any other North West London. But not to say we can't do better, more still, and we have to do better in order, particularly for some of the assumptions around the new hospital as well.
Philip, you wanted to use your second question.
I do. Thank you for indulging me, Chairman. My second question, just relating to discharge. Certainly in my time, one of the challenges associated with it was the extent to which the hospital was set up for 7-day discharge. It tended to be a Monday to Friday thing. Where are we now with that? Is that done and dusted? Is that still a challenge, or are we getting there?
So the answer to that is, like every hospital system I've ever worked in across the country, weekends are problematic for us, and I think I will touch on this in my paper. Fundamentally, what we're operating both in the hospital and in out of hospital services are principally 5-day services with different models of care at the weekend. And if I showed you a graph of discharges at the weekend, you would see they are only about a third of what we get on a weekday. Now I could go to any hospital in the country and find that. And there's a piece of work we've just started both across North West London, but also within Hillingdon with Tina there, is to look at what we can do to do that. And we'll pick that up when we come on to the wider HCP work. So it is an issue, Councillor, and we are trying to do something about that.
June.
Thank you, Chair. My concern is about the bullying and harassment and recommendation, because this has been ongoing from the time I lived in this borough now for 33 years or more. And it's something that's been ongoing from the time I know about Hillingdon, because I used to work in Hillingdon as well. And staff retention. Because if this is still ongoing and you cannot nip it in the bud, it's not going to help in regards to retaining staff, because it's an underlying thing that's happening there, and the recommendation of the hospital as well, because it does impact on patients when they're admitted. There's a massive impact in regards to that, because if there's bullying and harassment, then you can get the best out of your staff, because if the bully and the harasser is in the department or one of the member staff, it's not going to work. So what are you doing to work around to finding out exactly what is causing that, and to build a safe and open relationships with staff to be able to either whistleblow, which a lot of staff will not whistleblow, or to see how you can manage it and enable staff to feel free, but also give that good recommended impact on patients' care, where patients will be able to say, yes, Hillingdon is a very good hospital. And I had that as well with my dad when he was ill. It's not so much with the staff, it's the bully and the harasser and not wanting to speak or do things.
So, a number of things in your question. I'll try and break it down. So, the area of bullying and harassment, one, it's relatively small numbers, but it's relatively small numbers that have a big impact. Also, bullying and harassment, as it's reported in the staff survey, is bullying between staff, bullying and harassment between staff, and it's also bullying and harassment between staff and patients, or patients bullying staff. So we see quite high levels of staff being very threatened in our emergency departments and so forth. So it's a bit of a mix of both, and it's quite well, it's not difficult to unpick it. We are now starting to see some trend data that is helpful. So if I do the patients to staff, we have a zero tolerance policy. We have a very good security team who are incredibly supportive to staff, and if they're called, will act to reduce the tension. And we also have a number of courses through our security team for staff about how to calm down situations. So we've done a lot of work with that. In terms of staff on staff, or be it that it's between members of staff or between members of staff and their manager, what we are now doing is we're looking at that through the staff survey at departmental level, so we can see if there are particular departments that we've got problems. We have we do a lot of work around what we call our freedom to speak up policy, which is another word for whistleblowing. We are very clear with staff, and I'm very clear with staff at induction, that we want staff to speak up. And under the Francis inquiry, speaking up was very much about speaking up about safety of clinical services. We're really clear it's speaking up about anything you're concerned about. We have a freedom to speak up guardian who has a very high profile around the hospital and deals with a lot of issues, some of which actually, when you get under the skin of it, it's HR issues, but some of it is very genuine speaking up, and we have a policy and a system for investigating. We've had several situations over the last 12 to 18 months where we've brought in external investigators so that staff can actually talk to people external to the trust, and we then receive a report back, and then we have an action plan associated with that. I receive emails, I and colleagues receive emails or communications from staff. Sometimes they're anonymous, sometimes they're not, but we always go back to staff. Even if they're anonymous, we'll write back to the department and we will do an investigation. So I'm really clear this is something that is something we want to tackle as an organisation, and we're hoping that with the staff survey this time round we'll start to see a change in the trend there.
Thank you, Chair. Thank you, Patricia. Last time you were here, we heard about the savings that you were having to make, and I know we're rushing through, so we didn't have time to pick up on that, apart from the fact that you've got to NOF3 now. And I just wanted a little bit more understanding of how much progress you're making towards that deficit reduction, and what you're doing in the next financial year, really.
So our focus in terms of financial reduction has been very much about making sure that we are as efficient and productive as we can be, so that and quite a lot happened during COVID that meant that wasn't the case, and it has taken us longer than some of our other local trusts to get to that position. So, we weren't immediately able to open theatres after COVID because we were waiting to move into our new critical care unit, and it took more time for that to return. What we've been able to see in the last year is our focus has been on where we have excess cost spend, so using too much bank and agency where there's an excess cost, and actually we've been very successful, and fortunately until just recently we were very successful about reducing that excess cost, predominantly through really actively recruiting. So our reduction in vacancy rate means that during the year we've reduced our bank and agency spend. That has unfortunately gone back up again. Some of that is because we've got new services that have come online that it takes you a while to get up to full recruitment for those, and some of it because we made sure that staff were covered whilst they were doing their Cerner training. So we've seen a bit of a blip with that, and we're hoping that will now start to drop again. So where we've got ability to control spend, where we've got higher costs, we've absolutely taken action on that. We've looked at quite a lot of things like, are we being as efficient as we can in theatres? Are we maximising all our theatre sessions? We are now one of the best performing trusts across London in terms of theatre efficiency, and we're seeing the benefit of that in terms of more operations being done. What comes alongside that is we were set targets. We have been set targets for the last 2 years, which is that you had to get back to a certain percentage of pre-COVID level of activity. We met our target last year. We are exceeding our target this year, and that comes with money, so we've been able to attract more income. Our plans for 24-25 are more work on efficiency and productivity, but also an in-depth review of every service to say, you know, is this a fragile service? Is there a better way we could be providing it? Are there ways that we can work with our partners across North West London to think about how we might be able to combine some back office services, those sorts of things. So we're picking up the stones on all of that.
Yep. Sorry, Keith wants to come in on that.
Just to add something to what Patricia said, another element, which is why we're a system. The other element of the recovery plan for the trust is contingent upon the wider services. I hate the phrase, but out of hospital services being able to turn off some of the demand. So it is a joined up piece of work, this, and I think that's I think it's important to stress in this discussion.
No, good point.
I like that phrase, turn off the demand, because I think it's once you start turning off that demand and getting it earlier, you're solving a whole load of problems and issues that come to. I just wanted to ask a second question about the Cerner, because I think this is going to revolutionise the way you operate. And just kind of, do patients have access to this as well, or is it just a clinician to clinician, trust to trust?
So it's a trust electronic patient record. But what it means is that your hospital record is all in one place predominantly. We have it brought together a whole lot of disparate systems and paper-based systems, so it's now electronic. It means that we can communicate more quickly. You should be able to get your discharge letter faster. We can give more comprehensive information in terms of that communication. So patients get access to it because we can provide you with more information. Where it has advantages is that it does mean, so, and Richard, you'll remind me, so is it patient knows best? So we have, so we have a number of electronic systems across North West London that allow us to communicate with patients. And one of the things actually with Cerner now is that patients are getting their test results before the doctors have even had a chance to talk to them about it, because they just go straight through. And that, I'm seeing some nods, that is actually starting to be a bit of a problem, because your specialist consultant hasn't had a chance to say, by the way, that liver test says such and such, and I would have talked to you about it, whereas previously you'd have had to wait for a letter to come. So I think there are some real advantages. There is lots more that we need to do what we call optimise Cerner. So we are starting now to do a piece of work across the 4 acute trusts to say, how can we standardise clinical pathways? How can we make sure that tests are done in the same way, all of those sorts of things. And I think that will have some real positive advantage, but it's a massive piece of work to do.
Thank you. If I could just say that I had a recent experience which I thought was absolutely brilliant. I don't know if this has been going on for a long time, because I haven't used a hospital service for quite a while, but I was telephoned about an appointment. I got the appointment, the letter was there, so I didn't have to worry about whether I'd put the letter somewhere or anything like that. I could go onto the app, I could find all the communications on that app, and it meant that I didn't miss an appointment. I remembered everything. I knew what I had to bring, what I had to take, what I had to do beforehand, and I just thought that was absolutely brilliant.
Thank you.
I mean, I use the app as well, and Patient Knows Best, which I think is an odd name for it, but it is good. Mind you, I do get the test results and I don't understand what they are until I get the letter a few days later. So, but anyway, I do wait because I think if it was an absolute emergency, the phone call would happen. But the app and Patient Knows Best does work really well, so we can improve that. Thank you very much, Patricia. Okay, Ritu, do you want to say something on your own, or are you going to be part of what Richard and Keith are doing? Okay, fantastic. So we have a trio at the end. So Richard, Keith, and Ritu, do take it in a way in the style that you wish to.
Like a really bad 70s pop group, this one, isn't it? Yeah. you wouldn't book us for any dues, would you? So, Chair, thank you. And I think what's important to do is to view what we're about to say in the context of what you've just heard Patricia say in terms of urgent emergency care challenges, what you've heard Vanessa say in terms about the Heathrow villages, but equally what you've heard Clinton say in terms about alternative care pathways, because the whole point of this is the health and care system has to work in a more joined up way. So hopefully you've heard most of this before, so I will massively be brief for you all. So you will remember we've got three main priorities as a place partnership, and again the place partnership is the NHS providers in Hillingdon, is the third sector providers and local governments as well. So we've been strengthened this year really by the presence of the London Borough of Hillingdon playing a real full part in the partnership, and for us that's been quite a game changer for us in terms of how things have worked. So we've got three priorities. The first priority, and you've heard me talk about this before, is fundamentally we need to change the way we deliver care, particularly out of hospital care, local care, whichever phrase you are comfortable in using, because to be honest with you, it isn't fit for purpose. And you've begun to hear this in the context of the conversation, and I'll exemplify that in a minute with some data for you. So implementing a new model of care, operating model, whichever management jargon you are comfortable with, and it's about driving population health, matching the availability of services with how patients now want to access services, but also towards the activity shifts for the new hospital. So develop that model, and then you get no prizes for developing models on PowerPoint slides. It's about how we implement, how we make change happen on the ground for the people that we serve, and what the partnership has set are three key priority areas to implement in the next 12 months, and I'll describe where we are on that journey. The first area is around developing, again, you've heard me talk about this before, multi-agency neighbourhood teams. So those multi-agency neighbourhood teams anchored by our 6 primary care networks to do more preventative work and to improve access to same-day urgent primary care. And again, we've talked about that on a number of occasions, and I dare say we'll have today. The second area, and it links directly to what Patricia's spoken quite extensively about, is what we call implementing an active recovery service, and that fundamentally is how we prevent hospital admission, how we prevent attendance at ED and hospital admissions, and if people do need to be admitted, how we get them home as early as possible. And we think the data tells us around 18% of our ED attendances could be avoided with alternative care pathways. I think answer to your question, there's a number that we are working to.
That was 18, not 18.
Not 18. Don't people get excited about that? Patricia would love that if want me to silence that here. And then the third one, again, you've heard Vanessa talk about this earlier, is to implement a 24/7 integrated end-of-life service. We have been trying to do this in Hillingdon for 5 years. 6 years. We've managed to do it this year, and I'll come on to that in a moment. And then the third area, the third priority, is to make sure that basically is to make the money balance. And we tend to follow the view that good care, quality care, is cost-effective care. So that's what we've set out to do. So first thing is, where are we now? As you know, we have developed a new model of out-of-hospital care. It's been endorsed by all HCP partners, by our clinical senate. It's been to this group before, it's been to Health and Wellbeing Board. It's attached to the Appendix 1. It's known as the hexagons. If you really want to see the 40-page document, you can see the 40-page document. It's not Harry Potter, but actually, you're very welcome to read it. And the reason for developing that new model of care is threefold. It's basically we're struggling to match the demand consequences of an ageing population with complex multimorbidity. We're getting older. Councillor Cawthorne will remember the data. 6% of our population drives 70% of health and social care utilisation. The second area, and this is the bit that tends to frighten people a little bit, is our out-of-hospital services. Historical commissioning patterns have led to what I call a patchwork quilt of around 170 different services. So imagine you're the GP, imagine you're in the ED department, imagine you're the ambulance driver, and you're looking at this patient and you're thinking, I don't think this person needs to go to ED. Which of the 170 services are you at that point in time are you going to look to? And each of those 170 services will have their own referral patterns, will have their own. So when your constituents say we bounce around services, that's because there's an awful lot of services to bounce around. Yeah, and they tend to be small and they tend to be quite fragile. The second part of that is, without exception, with a small number of exceptions rather, we operate largely an office hours out of hospital service. It's 9 to 5. And Appendix 2, I've given you what we call a heat map. So, and if you only got a black and white slide, this is like watching the snooker on a black and white TV, I'm afraid. But what that heat map does, we use this as a proxy for demand, and it shows us when patients are accessing ED department. And what you'll see is that only 40% of ED attendances take place between the hours of 9 to 5. 60% take place weekends and after 5 o'clock in the evening. But our out-of-hospital services are running largely 9 to 5. Okay? So when we have conversations just about how things work, we've got a mismatch between the two. And I could go to any borough in North London, I go to any system in the country, and we'd find this here. So that's the challenge that we're facing, and what our plan is, and the scale. Chief execs talked this morning, place chief execs talked this morning about what we call the transformation, the change. Whatever noun you want, the change challenge here is what our plan is in the next 12 months is to take 34 existing services and to integrate them into 9 larger services. Why would you want to do that? Because it breaks down barriers, silos, makes us more patient focused. It drives productivity opportunities for us and more robust services. What it would allow us to do, and go back to Patricia's point earlier, is better match service availability to patient demand. It enables the hospital to drive better operational and financial outcomes because we're aligning the services, and that's a huge shift. It's a huge shift in terms of what we need to do. So that's the background. But do look at the heat map. We've split it for you in terms of the overall population, adults, children, and then care homes. And you can see, you can predict, you can use that, and I'm sure Richie would tell you, it's quite easy for us to work through when they went to see general practice, because normally the peak times in ED will be normally at the end of closure of surgery in the morning and then end of closure of surgery in the afternoon, and you'll see spikes about 2 hours later in the ED. So it's a good proxy for demand. So the second, in terms of implementation, where are we? So we are in the process of implementing, and this has changed since we last came here. We're in the process of implementing 3 multi-agency integrated neighbourhood teams. We were going to pick 6, but we've decided now only to integrate 3, built from those 6 primary care networks, but it better aligns us with local authority ward boundaries and adult social care. So we end up with a much more joined up, integrated offer, and we get some critical mass. What we plan to do is to co-locate these teams into fit-for-purpose neighbourhood hubs. And within each neighbourhood geography, we'd have a hub and spoke model. So with one super hub, and I'll talk a minute about what a super hub does, and one spoke hub to deliver services to the PCN. And what that does, it allows us to think about primary care at scale going forward. So each spoke hub will have a basic a range of integrated services. The super hubs will have additional services, so same-day urgent primary care, community mental health hubs, and as we work through time, we believe some access to diagnostics. Because again, what we know, one of the reasons people go to the ED department is they will get I may wait for 9 hours, but I will get me X-ray at the end of it. You know, so it's working through that logic. So we work with the council, and this is for us to break through, because we've been trying to do this now for about 5 or 10 years. I'm sure Richie will tell you about the primary care challenge. So we work with the council to fast track the development of same-day urgent primary care in the 3 super hubs. So Hayes Hub in Mead House went live in July. I think I reported that when I came in September. This week, a Ruislip Hub will go live in Pembroke House. And I think Vanessa and I have aged about 5 years in the last month in terms of we're really delighted to say that we believe a Uxbridge Hub will go live next year, and it will go live, I can get my geography here, at Beaufort House. To enable that, we work really closely with Tony and the council. We'll move the out-of-hospital management and admin for health into the civic centre, into the ground floor. Symbolically, and that's really quite an important step change for us to integrate care. So that's where we've got to in terms of that hub, and that's taken us quite some time to do, and some quite complex work.
Could I give you a couple more minutes?
You can. I'm nearly finished.
You're nearly finished. Fantastic.
So fundamentally, what the super hubs do is give us additional primary care capacity. They'll give us, when they're fully deployed, around 80,000 additional appointments a year. I will put that in the context at about 1.4 million GP appointments a year in Hillingdon. It's not a small industry by any stretch of the imagination, and it will help to divert from the ED and UTC. The final point, Chair, is just to say is that in November we finally went live with an integrated palliative care service known as PICS for short. Brought together people from Harlington Hospice, CNWL, into a single place, single building, single integrated service, and that's a major step forward for us. It's taken us quite some time to drive that through, and I think one of the things we can't underestimate is the culture, is the culture of bringing people together in teams. Is culture does really eat strategy for breakfast. It is true. To do that. So that's where we've got to, and what we just did today with chief execs is give a commitment to drive the transformation, to change in services over the next 12 months, because what we can't go on as we are is the feeling. And whilst health is always in flight while it's redesigning service, you can't take help offline. It is what we think this is a way which has got supported staff and partners to drive in a way that I think I've not seen before. So I will pause there if any of my colleagues.
Richard, is there anything else you want to add to what Keith said?
I think it's taken a lot of work, and our culture change is a major factor, but it's working with partners who are really committed to deliver this kind of project that we are planning to do, because it's to help the system, because unless we help each other, we will still be going around in circles with one partner not being able to cope and passing it on to the others. And the neighbourhood teams, we had a very useful discussion with our colleagues to see how we could deliver that. So the 3 hub and spoke, initially we had planned for 6, but the 3 big hubs, super hubs, and to reach places like Harefield or say other areas that are not served by primary care services, we would have that spoke model. So the facilities that we develop in these super hubs will not just be limited there, they'll be based there, but we can rotate these clinics so that the services go out to people where they are resident in. So I think it's been a big breakthrough, and amalgamating the services and thinking more sensibly and practically rather than fragment services into 6 different parts. It's more sensible to have these 3 super hubs and then get. So Ruislip Hub is going to go live tomorrow. I've just visited today to see how it's going to be in action. So that's a great development, and that sets the scene for the next hub, hopefully, as well.
Brilliant, thank you. Lisa, do you want to?
Thank you. I just want to say I think you've made incredible progress with this in a really short amount of time, and it's really exciting. I think one of the things that will support the success of this is patients and the local community understanding the new system and how it works. And feedback that I've received is that some of the language around this doesn't really mean a lot when you start talking about integrated neighbourhoods and
and community. So I just wanted to ask, are there any plans for how this is going to be communicated to the wider community, and what sort of plans are in place for educating people around how to use services, but also what they can expect, and also I think what the benefits to them will be. Thank you.
So we are using our community events when we are going out along with partners to meet people in different communities, and we've had these community events both in every sort of PCN, and we go jointly, not just primary care but community services, Hillingdon, H for All, and partners. And plus we've got our PPG groups, patient participation groups with each PCN. So they are also being they've been informed, and they are taking that role of informing more people. It's a lot of work. It's not done. It's also about even general practitioners understanding where we are getting to. So we're working at different levels to get this communication out. This is what we are doing. This is how it's going to progress, and this is the benefits of it. So yes, it's work in progress, but we are doing it, and carry on doing it, because the more we communicate to people, the more they will understand how to utilize the services more appropriately, because dealing with the demand at the moment is really a big ask, and I think that's kind of it's in every area. And I think unless we communicate to people and educate them and show that we as a team are trying to provide these services and you can access it, plus also that trust builds up from the patients as well, because they understand that it is a place-based service, and it's not somebody random contacting them for something.
I think it's a very good point, because the words like super hub, for example, don't mean much to most people. How it's communicated, why people should go there, and the benefits of going there. Maybe using the app, or maybe using other outlets. I don't know if the council might want to promote stuff, because I'm sure it'd be in the council's interest as well. But yeah, something that's really important to do. Okay, just before I take questions, I like the fact that things are moving forward, and that's really great, because last meeting we had the beautiful PowerPoint slide, and the challenge set to you was, what does that mean in reality? And now we're starting to see stuff in reality. So and bringing people together is not easy. I do understand that. So that is very positive. Rita.
Thank you, Chair. Two quick questions around the hub. So is it a referral from the GP to go to the hub, or can you walk in? And also, since Hayes went live, what's the feedback there? What's the waiting time? And the reason I ask is I've just dropped a family member off at Hillingdon Hospital for an X-ray, because we went to the GP, and GP said take him to hospital for an X-ray. If I'd known I would tell him to wait till tomorrow and go to Ruislip.
The X-ray there is at the moment, but that's not there at the moment. So it's expanding that capacity, and as Keith said, we plan to give that many appointments, increase the capacity just to support general practice and preventing an overflow into ED. But to support that, we need the diagnostics, and that's a big thing that Hillingdon does lack. While other boroughs do have community diagnostics, this is something we're working on. Hayes, fortunately, we do have an ultrasound there, but in Ruislip it's just starting, so we're going to be working with our partners to see what sort of diagnostics capability we can put in the hub, so that patients don't feel the need to go to the hospital just to get that. No, it's not there yet.
On the question of can people just turn up, or do they need to be referred?
No, at the moment it's a referral system, and there's a referral system not just from GPs, but we have 111, plus also the UTC can divert patients. So as these things progress, then we look at expanding it, because the idea of the hub is to have some referral pathways, but people also walking in, whether they need to be talking to a social prescriber, or they could be a health and well-being coach, utilizing our extended workforce to deal with some of the demand that the public has at the moment.
June.
Thank you, Chair. Keith, can you clarify what it is that is going to be going into the Civic Centre? Would it be a hub? Would it be system? Can you just explain?
I can.
A brief of what it is that's going to go into the Civic Centre?
So we've got quite a complex choreography of people moving across accommodation. So the clinical staff will all be based in Beaufort House, so across the road. To enable clinical staff to move into Beaufort House to create the space, the management and admin staff who are currently in Beaufort House, so CNWL management staff, my team of staff, there are some of the Confed are already in the building, and the ICB borough staff who are currently in Boundary House, wherever that is, would move into the ground floor of the Civic Centre. And what we'd end up with is the place leadership being in one place. So there'd be no clinical services running from the Civic Centre. What it would allow us to do is to use our existing estate footprint at Beaufort to create an integrated neighbourhood hub to bring together staff from lots of different bits of accommodation across Uxbridge, so that actually it's about relationships. Fundamentally, it's allowing people who work together to build relationships around the people they serve, and putting them into a building is a really important way of doing that. And we feel really strongly that unless we get to co-location, we'll never develop that infrastructure in the community that allows us to do the sort of things that Ritu has said. So there are no clinical staff going into the Civic Centre. It's our manager and admin staff. And what it does is it enriches the place-based working, so we can walk along the corridor and talk to Tony or whoever it is, and that's a real strength, I think, for Hillingdon. It's one of the first to do that, really is, and it's quite a sea change for us in Hillingdon compared to maybe 3 years ago. I think it's to be applauded, personally.
Thank you, June. Philip.
Thank you. 2 questions from me, Keith. All sounds very encouraging and positive. My first question is, you talked about LBH playing a full part in the context of the ICP. Can you explain what you mean by that? What's changed? That's the first thing. And the second question is, I think you said Mead House in the context of these super house hubs, if I'm not mistaken. There is this information is in the public domain. There is on the forward plan for February, I think, a cabinet decision about the future of Mead House. Presumably you're aware of that. Yeah. Okay. So those 2 questions.
So I think the sea change for us is engagement in the governance of place. So whether it be from Sandra Taylor, Tony Zayman have played a full role in all those governance arrangements that we've. So, for example, at the chief executive meeting this morning, all the place chief execs were there. Tony was there in that meeting, playing a full part in those discussions. And it's the same at our delivery board. Sandra Taylor comes to that. Gavin Fernandez. So we're working as a team to solve some of the place challenges that we've got, and some of the things that Patricia described around discharge we could not have done without the local authority being involved in that process. And I would say this, wouldn't I? Certainly the relationships that we have in Hillingdon are the envy of North West London in terms of the relationship between health and local government. I think I'd say that without fear of contradiction.
Adam.
Thank you, Chair. So it's fantastic progress. It sounds really exciting to have these hubs, but I guess my question to you is, what are we doing about getting residents access to their GP in the first place? Because all of this still hinges on the GP having to make a referral. I look at Tony because we live very close together. We may share the same GP. But if I ring up my GP, and I don't do it that often to be fair, but I am never less than number 30 on the queue, and it never takes less than an hour. And it is a bit of a postcode lottery, because when I used to do it for my grandmother, she lived in Hammersmith, much denser area. You could ring any time of the day and you were straight through. What work is being undertaken to try and reduce that waiting time? Because I guess there's quite a high lost call rate where people just hang up and then they present themselves at A&E, for example.
So one of the things that we've done in Hillingdon is that all the practices have gone to a cloud-based telephony system, which enables people the callback option. So the calls, the volume of calls, if you sit in a GP surgery, is just unreal at the moment. And throughout the day, you may deal with about 300 to up to 500 calls in a medium-sized surgery, I would say. So that has enabled us to work together. Moving forwards, what we're planning to do is to utilize cloud telephony in a way that we can bring it to bigger hubs, basically, just to ease the pressure and have larger call centers, because in every GP surgery you will have 2 receptionists, 3 receptionists, and the volume of calls and you can't stop people talking either once you get onto the call either. So it's trying to move to a modern general practice, and that's what every practice is working towards, is how are they going to deal with the demand, how can you make it slicker for patients to call in and be signposted. So a lot of signposting programs are going on, referral to pharmacy. Unfortunately, it's all through the GP system, and that's why the time lag. So that's what we're working on, whether these super hubs can be one of the diversions for urgent care. So that's the ethos. If you take away that urgent demand, then you can deliver better care for people who have long-term conditions, which really need the continuity of care in general practice. So that's work, and every practice is working towards this modern general practice movement towards that.
Thank you. Still.
Just to support, we know from analysis that around 1/3 of all calls to GPs are from people who fundamentally have no underlying conditions and have a short-term illness, for whom actually continuity of care is not that important. They just want it to be sorted, and they're the category of patients who actually would do better from a hub arrangement. It's the people with lots of underlying conditions for whom continuity of care is really important. They need to see the same GP, although they can't get access because 1/3 of calls are for people who are fundamentally okay. They just need some episodic care. So what we're trying to do in a systematic way is to create the hub infrastructure to stream people to the right to the right place. And that's not just us being clever. That's a Northwest London. That is a Northwest London strategy in terms of what we're trying to do. So there is some science, and we've got some data underneath that that allows us to think through the call volumes and so on and so forth.
Thanks. Cecil.
Thank you. I just want to follow up because I think it's a really good question, Adam. And just wanted to, because I'm not so sure that was answered in the way that I understood it really well, because it still relies on GP referral even at the hub. So therefore, I can't, if I've got a cold, I still can't walk up into the hub. I still have to call the GP practice. And therefore, I understand that you want to have a call centre base there at that hub that diverts from the people phoning the GP to go to the hub. Is that my understanding?
So there are various tools that we are using. One is online access, which is through things like patches or e-consult or whatever you may call them. And there's an online booking system as well. So there are various things that are being, at the moment, are working. And one of the possibilities in a hub is to use patches where the patient gives information, and it is for people who are digitally enabled, and that's usually the younger population who want their care needs addressed very quickly. So that will be streamlined. So that will not involve GP, and we can use all these appointments and we can bring them together. We've done it as a e-hub before during COVID, and that's a possibility again. So it doesn't really need to be accessed by the GP and then passed on. So it will be more administrative, but that's the streamlining, and various PCNs are working on a triage model as to how you can filter these requests and deal with them very quickly, because you've got pharmacists now, we've got a larger workforce, we've got paramedics, we've got PAs and nursing staff as well, and you've got physiotherapists working in general practice as part of primary care networks. So those are the people that can filter out and address any kind of need that can be dealt with safely.
Thank you. If I can now answer my original question, please. So I think obviously amazing progress since you last came here, and this idea of integrating 34 services shows how fragmented actually primary care has been, and it's a little bit like the Thrive map that we were looking at, which again, mental health is so fragmented. And I just wanted to ask about the duplicate delivery of some of these groups? Because is that what you're trying to address as well? Because it feels like maybe there might be 5 smaller groups delivering the same, but then are some of them really specialised, and are they being brought together, or are they just being disbanded?
So the answer to that, you've done an analysis, you're absolutely right. So if you speak to patients, they'll talk about the procession of faces. they'll see the same person coming down, or different people coming down the path to ask them the same things. And we've done an analysis looking at the caseloads of comparing, say, district nurses with members of the care connection teams. And what we found is that there is an overlap. There's around a 5 to 10% overlap of patients who actually fundamentally are being seen by a nurse. You may change the label, but they're still being seen by a nurse. So one of the things we want to try and do is what you're alluding to, is if we create a larger pool of staff, we can use the resource more flexibly, we can drive out productivity, we can see more patients, and actually people only get 1 visit rather than 2 visits or 3 visits. Because what's happened, be careful what I say, the risk is we become increasingly more specialised and we lose the generalism out of what we're doing, and 80% of what we do is general. 20% is the specialist component, and the risk is we over-specialise, and we end up with lots of people rather than actually empowering one person to sort the issue out. So that's what's behind it, and there is, again, some data underneath it, because we've analysed caseloads and looked at these to say, you know what, there's got to be a better way of organising this, which uses our workforce in a much more flexible way.
Is this a sort of Hillingdon-specific venture, or is this a North West London type of ambition? I mean, the reason why I wanted to ask is it does sound very good, and you know, things have moved forward very, very well. But is this something that's coming from us and the healthcare partnership here, or is it something being driven more from North West London level?
Sorry, excuse the hideous laughter on that. So, there's a North West London strategy. In terms of this approach is a North West London strategy. I would make the point there's a difference between a PowerPoint slide deck and operationalising it. And what we're doing here, I think, is operationalising it, because the way we're trying to drive change is through frontline staff, operational leaders saying, well, actually, you know, unless an operational leader says to somebody on a Friday, we're going to do something different on a Monday, change never happens. So it's that approach. I think where we are ahead is we try and move more quickly from thinking about things to doing it, and I think that is the difference between us and what we do elsewhere. We tend not to ask for permission an awful lot.
I approve of that method. Right, Tony.
Yeah, thank you, and it's encouraging to hear how things have progressed so much. It all seems happening, all to be happening. How have you got the GPs and workforce to buy into it, and have you learnt lessons starting at Hayes, and have you what lessons have you learnt?
And we can talk about end of life, I think, on this one, Vanessa. The honest answer is, when we first tried to do this, there was quite significant resistance to doing this, because what you're doing is you're taking people out of organisational silos in ways of working that they become, they know, they're comfortable with, and you're asking to work with a different cohort of people in a different way. And what we had to do, the lesson we learned, is we had to take a couple of steps back in the end of life. We had to, let's just put the PowerPoint slide next to a side for a minute. Let's engage with staff around why we're doing this, and why it's important to the people that we serve, and why it's going to be better for people. So I think what we learned, that we lost a couple of months, but it was well worth investing the time. And the lesson for us is, if we'd have done that at the head of the process, we'd have probably got there a little bit quicker. Because unless people own it, and you spend the time investing with them, saying this is why it's important, in language that they understand, so you don't put people like me in front of clinicians, you know what I mean? I mean, you see people who talk plain English. So I mean, I think it's that sort of thing you need to do. People they trust, telling them this is going to work. So we've learned that, and I think we've learned that very much with GPs. And whether you want to talk about the challenges we've had getting GPs on board with some of these things.
it's the communication out to GPs and making them understand why we are doing that change. Because change is always difficult to implement, and it's the culture change, it's the way you work. And I think we've done it slowly in Hillingdon, and I think we're getting there because we started off working with the Care Connection teams where we worked with CNWL staff, and we've got teams with our voluntary agency and GPs working together. We've also got our wider primary care community teams working together, and that's again been implemented because over COVID all these meetings stopped, so you could discuss them quickly. Okay, this is the health visitor sitting with you, and you've got the palliative care nurse, you've got your heart failure nurse, and you've got your district nurses plus the practice teams. That has been implemented again, so people are bought into it because they know that it helps them deliver care. It takes the burden off doing it all by themselves. And I think that's why people are bought into it. And I think in Hillingdon we're in a good place that people understand the why of what we're doing and why this change needs to happen. So everybody's bought into it. Yes, I can't say that every GP is going to be working, but that's the push. And as PCNs, I think the clinical directors are trying to feed that into the primary care networks as well to demonstrate the advantages. And people are generally bought into this change.
Okay, go on, one more, because I've just one more, go on.
I just want to say I applaud the effort of implementing change when systems are really pressurised, because that's what you're doing at the moment. The GP system is so pressurised that I can imagine resistance to change, because change takes mental absorption, change takes time, change takes participation, and when you're seeing 500 calls a day, you've not got time for that participation. So I have to say I would like to applaud that, and I would also like to say that it's refreshing to hear something positive coming out of COVID in terms of how communication was successful during that time, because people had the time for different circumstances. So that's a lesson well learned, and that was what I was trying to say.
Good points, well made. So I'm going to draw this agenda item to a close now. And even though everybody did stick to the rules at the beginning, so thank you to everyone, we still took almost over 2.5 hours talking about all this stuff, but all really interesting things. So thank you so much for coming along and staying till the end. You may all leave unless you want to hear about the budget. Obviously, our finance people, you're welcome to come up. Apologies about being a bit later than we said we would, but thank you for staying. Right, okay, so I can't remember what's the next agenda item. I know what it is. What number is it? Number 6. Okay, so we're here to talk about the budget. Obviously assume the paper's been read, so you may give a short presentation if you wish to, but obviously don't feel like you need to say too much more than what's in the paper.
Thank you, Chair. So today I'll be taking you through the budget report for the Council from the consultation budget presented to December Cabinet. So this is the second appearance of Finance at the Select Committee for the new budget cycle. We'll be presenting the detailed budget proposals within the remit of this committee. The feedback from this committee will then be included in the budget report, which will be presented to February Cabinet, where Cabinet will be asked to approve the proposals to full council. So I won't run through the whole report, and I'll just run through the kind of headlines. So in terms of the Council's revenue monitoring, for 23-24, the Council reporting a net underspend of £2,000, with the services within the remit of this committee forecast to underspend by £1 million, with this underspend being driven by staffing underspends due to recruitment difficulties in the sector, with adult social care placements forecasting an overspend, which is being funded by a one-off release from balance sheet provisions. Within these services, there are £2.4 million of savings to be delivered in 23-24, with all of the savings being recorded as either banked or in strong delivery in progress. In terms of the Council's medium-term financial forecast and the budget strategy, in the consultation budget presented to December Cabinet, the Council's saving requirement up to 28-29 was estimated to be 51 million, with saving programme identified of 33.4, leaving a residual gap of 17.6 million. The single largest factor in the strategy continues to be exceptional inflation. This is adding £48.1 million to the budget gap. Within the remit of this committee, adult social care placements continue to drive much of that inflationary requirement, with a forecast increase of 7.8%, which is in line with the ADAS forecast for the future for 24-25, leading to a total requirement within the remit of this committee of 21 million out of the Council's total 48 million over the 5-year period, with placements accounting for 15 million of this value. The forecast pay award adds another 3.2, and the remaining balance of 2.8 million is being driven by other contracted expenditure. Service pressures are forecast to add 24 million from the impact of demographic growth. Services within the remit of this committee are accounting for 4.6 million of that figure, with 4.2 million of that linked to increase in support for adult social care demand. Finally, corporate items are adding 14 million to the saving requirement, with 7 million of this being driven by the Council's borrowing requirement to fund the capital programme, and 5 million from the TfL concessionary fares levy as a result of demand returning to pre-pandemic levels, with these corporate elements sitting outside of the remit of this committee. Following the work carried out during the autumn, the consultation budget presented a saving programme of 33.4 million, with 15.8 million of that being required to balance the 24-25 budget. Within this programme, 3 million falls within the remit of this committee, with 1.7 million being required in 24-25. The largest savings include £1 million related to mental health recovery and post-pandemic reablement, with 0.4 million relating to realigning staffing budgets based on current occupancy rates, and 0.3 million from smaller items as set out in the report. Finally, moving on to capital, a capital programme budget of 218 million has been proposed for going up to 28-29 in the consultation budget, with 20 million of this being within the remit of this committee, the majority of which relates to £14 million investment in social care equipment, with the remaining 6 million relating to the Council setting up its own care home, with the investment supporting a saving of 550,000 per annum from 25-26. Thank you, Chair.
Thank you. Firstly, thank you to you and all your team for doing all this work. I know it's a lot of work, but very, very important and useful. So please pass our thanks on to the team. The main question that I had was around the sort of setting up, purchasing our own care home. So I can see the great benefits of that, but obviously also I'm aware that few of the councils that have got into really deep troubles have partly been through taking, shall we say, positive financial risks, which in the end collapsing. Now I know we're not buying a shopping centre hoping that it will be okay, but can you talk to me a bit about how we're going to manage the risks involved of doing such a venture?
Certainly. So within the capital programme, it is being funded through prudential borrowing, but the council is one of the lowest in London on the level of indebtedness, which means that we've got a lower risk to exposure in that area. We're also seeing that much of the drivers of the expenditure related to inflation. We're seeing the 7.79% across social care placements forecast for next year, which is in line with the ADAS forecast. But we're seeing the pay award coming in lower than that rate, We've got energy running negative next year, so it's currently set to reduce by over 30%, giving over a £2 million benefit to the council. So at the moment we're seeing that the cost drivers of running our own in-house provision, having lower exposure to those kind of price increases than through the open market. Obviously we'll keep this under review, but at the moment this seems like the most sensible way. As you say, in the past there have been exposure to risk by going down this road, but currently we're seeing the local authority sector kind of moving back towards that kind of purchased ownership and running of in-house services. Thank you.
Philip.
Thank you. Can I just say on your question, Chairman, the purchase of a care home, I think it's a great thing to do. It shows a pragmatic approach. If we think we can do a better job in-house, all things considered, so we should, and I applaud that, and that's welcome, I think. My question is around what we're talking about in the section 40 here, about developing ways of working in service provision to help manage pressures and deliver savings. I just wonder how well developed this is at this stage, and what might look and feel different from a service user perspective moving forward as a result of these changes. Is there any more information on that? Thank you.
Yeah, so we've got a MTFF proposal around developing our reablement plan, and that to try and obviously prevent the costs of people coming into the service, and making sure that they don't come in at a higher cost. We've got 500k in the MTFF this year, which is looking to be banked, and we've got 500k for next year as well, which is on track to be banked as well.
If I may, so again, I'm going to make a statement. You can correct me if I'm wrong. So would it be reasonable to say then that service users will experience no diminution of services this coming year? They may receive perhaps a different way of receiving services, but essentially they will have what they've always had.
Can I add something to your question, Philip? I mean, how are we going to monitor that and make sure? Because obviously we all understand the financial pressures, and having to redo services in different ways to meet the changing world financial, absolutely fine. But obviously as a committee, we're very keen on knowing that services are still being delivered to a good standard, and also our statutory duties are being met. So, that adding to Philip's question, how is that going to be monitored and ensured?
So, in response to what we're doing differently, I think there's a move towards using more occupational health and telecare services to make sure we do drive that reablement, and I think there's a focus on getting the reablement services to the clients as soon as possible. In terms of how we're tracking it, there is a model being developed to track the opportunity cost at the moment. I haven't actually seen it yet, but I know it's in development.
If I can just add to that as well, I think one of the other benefits to pick out is that reablement actually tends to increase the quality of life. So you're not just giving them a piece of equipment and kind of sending them on the way. You're enabling them to live more independently, which a lot of people tend to prefer. So it's increasing that dignity and care as well.
I think it's something definitely we'd want to, as a committee, come back and look at some point, is that tracking model and how it's done, because that is, obviously that's very crucial. So thank you. Cecil.
Thank you, Chair, and thank you for this. We've met a couple of times now in different committees. My question on this one was just because we were hearing about care homes, social care, we've heard about hospitals and stuff. So I just wanted to understand the rationale behind, because it feels like the social care demand drops, or our kind of costs drop on social care, yet it seems to be part of the demand-led growth of the council's budget. So I just kind of wanted to understand the rationale behind social care and why it drops in money, but is still part of the demand-led growth.
Certainly, Councillor. So the way we approach the budget strategy is to do, we report on it in a kind of gross method. So we show the demand-led growth, which is from the demographic pressures, and then we show the savings separately rather than showing a net figure. So by doing that, we're trying to increase the amount of transparency that we've got within the Council's budget strategy. So you'll see in the demand-led growth area that we're adding, I think it's over 3 million for demography, and then we're then taking out the saving from those mitigating actions. And we then also increase the transparency through the budget monitoring process, because by having it as a saving, we then report on the council savings. So you'll see the banked green, amber, red kind of traffic light system against those. So you'll see that we've set up a prudent budget strategy that puts the money in for demography, and then we then show you how we're looking to mitigate some of those kind of front door pressures, and then we can then feed that all back through Cabinet and through these committees, so you get to see the kind of whole piece and how it all fits together.
Okay, thank you.
June.
Thank you, Chair. Mine is on item 10, and it's the last two paragraphs, which is saving will ultimately be banked in full or replaced with an alternative measure. What is the alternative measure? I'll give you another question I have. Should I just do one by one?
Yeah, one by deal with that one, then come back for your second, June, please. Microphone.
I'm sorry, I don't actually have the pack with me to hand. Thank you. Thank you very much. So it's the alternative measures in question 10. Okay, so when we carry out the Council's budget monitoring process, we report back on the savings, and then we report holistically on what's happening across the whole of the Council in terms of our spend, what's driving the expenditure, what's driving the income, that kind of whole piece around your budget is your plan for the year and how is that plan being progressed. So what the benefit of doing monthly budget monitoring is that we're able to pick up on risks early and then put in place mitigating actions. So if we see that a saving isn't going to deliver the amount in the financial year, we can then look at what measures we can then put in place to try and bring that back within the year. So at the moment, the savings that we've got in here, all of them are expected to continue and ultimately be delivered. But if the full amount isn't delivered in year, we'll look at mitigating actions. So some of that can be around cost control, so we may look at our recruitment approach and whether we can just delay that slightly, and just because a slight delay across the whole of the council's churn on staffing can deliver quite a large benefit. We can also make sure we're negotiating prices better and through our procurement colleagues and mitigating the inflationary impacts on expenditure. So it's just that kind of whole piece of pulling together what we can do to deliver benefits to mitigate any saving risks. Thank you.
Thank you. And we still only have two questions?
I mean, it's 9:25 June. I mean, as much as I know I love talking about the budget, which is very, very important. So, I mean, do you know what? You can have three questions. You can have another two questions, so 3 questions overall.
Okay.
Is that okay?
Thank you, Chair. Item 16, you've got there's a 30% uplift in the core government grant that support would be necessary in order to balance later this year. What is the 30% uplift? And if not forthcoming, how will this affect later years?
Thank you, Councillor. So at the moment, the local government sector has only had a settlement that runs to the end of 24-25. So we have no real visibility of government funding from 25-26 onwards. We have been lobbying as a sector across London, across nationally, but at the moment, DLAC have been reluctant to give us an indication of what that might look like. So at the moment, what we're saying is that we're keeping the settlement flat in terms of the cash amounts that we're getting from government, with a view to waiting to see what happens, because that's the most kind of prudent approach, and that is kind of what the whole sector is doing at the moment. In terms of the way the council is funded, 75% comes from retained council tax and business rates, and roughly 25% then comes from government grants. So it's that 25% piece around the whole government funding and the grants that we just don't have the clarity on at the moment.
Thank you. My last question is on budget proposal for item 32, service expenditure. And the way the table is presented, it's a bit confusing for us. There's two headings with 3 lines, yeah? And within the 3 lines, is 12 million is coming out of the corporate budget. Where is that coming from?
Apologies if the table's a little unclear. There's 3 headings in there. So you've got the Health and Social Care Select Committee. So the first row is everything within the remit of this committee. The middle row is all of the services that sit outside of this committee. And then the bottom one is the corporate budgets and cross-cutting. So that 12.2 million is actually related to the services outside of this committee. The majority of the savings sit within the resident services portfolio.
But it's not us. Right, Adam.
Hopefully a quick question, or actually it might be not. What gives you cause for optimism? So it's been financially a really challenging time over the last sort of 4 or 5 years. But as you look at sort of health and social care from a finance perspective, as you get further into the MTFF?
I almost want it to be a long answer, actually.
Yeah.
A long answer might be better.
Don't keep you awake at night?
So I'll cover off the kind of strategic finance kind of piece, and then I might hand you over to John to kind of cover off a bit more on the social care side. So in terms of optimism, we're looking at the inflation rates that most of the sector are kind of forecasting. That's across London, London-based banks, etc., and across national. Looking at the average kind of percentages and drivers and the kind of trend pattern in those. So at the moment, what they're saying really is that we're expecting CPI to average out at 7% for 23, dropping to 3% for 24. But what we are seeing now is that the inflation is kind of running at a bit of a lag. So when providers come to us and say that they want to negotiate prices, they're saying, well, I've seen a 7% increase, therefore I want 7%. So that's why you kind of have a staggering now in that kind of contracted inflation piece. And in terms of the demand side, when we look at the ONS kind of population projections across the whole of the borough, how they're looking to play out. Most of the demand on the social care side on the churn basis is from the kind of older people, which is roughly at 2%. But when you look at the lower age groups, it actually drops down to 1% for working age. And the children population projections actually goes negative over the 5-year MTFF. So I wouldn't say that that's an optimism piece, but it's an indication that perhaps where that churn and that growth in demand is coming may slow down. But when we're looking at kind of 5-10 year projections, it's something that we're just keeping an eye on, but I wouldn't really say that the council's budget strategy is based on optimism. I think it's quite a prudent strategy and enables us to therefore be more resilient going forward by having that level of prudence in there. Jonathan, do you want to add anything on social care?
Just that we've obviously managed the demographic pressures quite well and the inflation pressures quite well this year. We've got some short-term pressures around COVID legacy and various things like NHS waiting lists and stuff that are sort of prolonging treatment, which is then having a knock-on impact. But we're managing that. We've made assumptions in the budget to account for that. And I think we've got a really great service who are coming up with great innovative ideas, MTFF proposals year after year that are helping us manage within our budget and sort of mitigate some of these pressures that we're coming from. So I think that the room for optimism is around how we're managing the budget robustly managing with the service to manage the budget robustly. So I think I've got confidence going forward that even despite all of the pressures coming at us, we're gonna be all right, I think.
Brilliant, thank you. A nice way to end this item. I propose that the formation and submission of the committee's budget comments be delegated to the Democratic, Civic and Ceremonial Manager in conjunction with the Chair and in consultation with the Opposition Lead. Essentially, that is the paragraph that we write. Will be written by Nikki. I'll have a look at it. I'll speak to Sital about it and then we'll submit it. Does anybody want to second that? Yeah, brilliant, fantastic. And we all agree? Is that okay? Fantastic. Okay, thank you. Thank you for being with us so late. You can go now if you wish. Okay, we move on to our next item, which is item 7, which is our final draft of our review into the CAMHS referral pathway. As we know, in previous meetings we've agreed on the recommendations, which are on page 37, and this is essentially just to sort of sign off the text. Obviously, thank you to all those involved, including Vanessa's team, very much for being involved with us, and also Lisa, in terms of giving us extra intelligence about what's happening in the world. Very, very important when we do these reviews to have good engagement and also to get wider views from people. Does anybody have any comments on this? Cecil?
I do. I just wanted to say that upon reading this report, that I felt really proud to be involved in this report. As the chair knows, that I have lots of personal reasons why I feel that CAMHS and children and mental health needs to be addressed. I really appreciated our honesty in this report, how our recommendations are action driven, they are relative, and they are to support better communications, which is what we found throughout the witness statements were really lacking. And I like the fact that it's not about a blame culture, but it's about a positive step forward culture, and it endorses, I think, and acknowledges all the work that partners across the health partners have put into this agenda and the gaps that it needs to address in it. So thank you so much, Nikki, and thank you, Chair, for putting this together and putting this as a review.
Thanks to all the committee members as well being involved, because it was an interesting review. So, Philip.
I'll go along with all of that. I'll sound a slightly Eeyore-ish note, if I may, because I was reading this at the weekend. It's all good stuff, but I'm just very aware that this isn't the first time that we've, perhaps not us, but colleagues elsewhere have looked at the very same topic, made similar recommendations, I imagine, and who can remember any of that? My slight concern is if we're not careful, we don't want this disappearing into ether. This really needs to stand the test of time. And I'm just keen that, with all these recommendations, we've got a real focus on clear and unambiguous performance and progress and improvements in service experience to the extent we can. Nailing down progress in CAMHS is bloody difficult. Yeah, if I was to pay a fine for saying that, that's fine.
Well, we're past the watershed, so...
Oh, we are. That's okay.
So I suppose it's all right.
But in all seriousness, it's important we nail that to the ground as best we can. So absolutely go along with what was said. It's a great report.
Okay, well,
I'll just throw in that note, if I may.
No, that's very fair. I mean, obviously, I know Vanessa's here, who oversees the service at a higher level. Ultimately, a year after the report, we asked for a detailed update. But of course, Vanessa comes to see us regularly as well. So there is plenty of opportunities to ask questions and see what's going on. So, thank you, June.
I just quickly want to say thank you very much, Nikki, for the hard work you put in. It's nice to see the concerns that we raised throughout. I've been on this committee now coming up, is it my 4th year? And to see the work that we discuss, the interviews that we have with witnesses, and to see it on paper form here. I just want to say thank you, and hopefully, like Philip said, that we can see something being done about it and not just a report that is come out and endorsed by Cabinet and nothing goes through. So by the grace of God, we hope that we can see some progress work through that and we can see some outcome from it, because with CAMHS and our children's services as well as children and adult mental health services, there's a lot come out from here. So I'm hoping to see some kind of work in progress with this and to see it going through via CAMHS and to see what they can deliver for our residents, because a lot of our residents has been really not done very well in regards to this.
Thanks, June. No, I'd agree with all that. I mean, one of the things about doing this report, I think we all felt the pressure of it, because obviously it's such an important issue, especially when you're speaking to some of the families involved as well, and I know everyone feels that within the service. So it did really feel like we had to try and do the best job possible, because it's such an important issue. Before I close the meeting, close this agenda item, do you want to say anything, Lisa or Vanessa? I know you've both very politely stayed here and listened to the budget, so you don't have to, but you can have an opportunity to say anything on this item if you wish to. Vanessa, do you want to go first?
Yeah, shall I start? Yeah, no, I was really keen to absolutely wait for this agenda item because, as everyone said, it's close to my heart. It's a service that we run in CNWL, and I think broader than that, I am keen that we think about the external organisations that also. So kind of to Keith's point around kind of why we're here, why we work together in Hillingdon as a system, it's not just us delivering our services and then we walk away. It's actually more than that. So I was keen to kind of think, I want to take this back to my team. So once it's obviously been through the right process, I want to make sure that we are then both delivering the actions that we've got in the recommendations, but that I'm also providing as part of my update, so they actually reflect what we've said, and that you actually have some evidence and some data to back up, hopefully, the improvements that we're seeing.
Great, no, thank you. And it should we should be signing it off. The cabinet should be signing off in February, which is like mid-February. So we'll let you know. But thank you for that.
Okay, thank you.
Lisa.
Just to add to that, I think is just that yes, I totally agree with what you're saying. That actually this is something that's been visited before, and we're here again. But I think for me it feels like this time there's far more investment in making change and improving services, and I will be starting a programme of work over the next year which looks at reviewing that Thrive mapping process and taking that to the next step further, which is then identifying actually what is going to work for not only children, young people and their families, but also within integrated neighbourhoods and support professionals actually to around referrals, but also utilising early intervention and the voluntary sector services that are out there as well. So I do think it's promising.
Good, and that'll be very useful for us in terms of reviewing what's happening as well. So a great bit of work there. So it's great when we all combine. Just as a note, we have asked for permission to attach the Thrive map to the final report. It's not ours, so we need permission just purely because I think it just visually shows so well what's going on. So I think Cabinet would appreciate that. But we're just waiting for that, aren't we, Lisa? Yeah. Yeah. You see, fantastic. Okay, so we're all happy to sign off. Fantastic. Thank you, everyone. Right, we have one more agenda item, but you are free to leave if you wish to. I mean, it should be quick, I hope. Is there three? Oh, yeah. Right, okay. Yeah, there's three, definitely leave. Okay, so that's right. The next agenda item is the health scrutiny and the new reconfigure arrangements. There's 2 points I want to make on this. First point is that I think this was, even though it's a short paper, it's a very well written paper, purely because it expresses really well what we're about. So particularly the sort of second paragraph and the last paragraph, I definitely want it in our yearly reviews, setting up what we're all about, because actually reading that again made me thought, actually that's a really good summary of why we do what we do and why we have these meetings. The second point I wanted to make is, in my opinion, this change of power makes no practical difference to our whole way of working, because ultimately the power we had to refer to Secretary of State was not really a power that was ever could be used properly. We did some research into it when Michael Sobel Hospice was going through problems, and we found out basically it's not a power that you can really use too much. I mean, I think our main powers are compelling people to come and speak to us and getting information, and ultimately referring to regulators if we wish to. I mean, that, in terms of the way anyone can do. So those are my 2 points on this paper. Does anybody have any questions? No? So fine. Excellent. Good stuff. Cabinet Forward Plan. Does anybody have any comments on the Cabinet Forward Plan? No? Fantastic. We can move on to the next one. And the work programme... Okay, yes. So, yes. Yes, go for it. Go for it. I was going to say something, but you go.
I'm sorry, Chair. I just wondered, it would be really interesting for, if there was visits planned anywhere, to go and see that hub.
Yes.
I just would
That's
like
a great
to see
idea.
how... Just
Perfect.
what it means, because I still can't get my head wrapped around it.
Nikki, can
you know what I mean?
Nikki, I think that's a really great idea. Yeah. Nikki, can you contact Keith and for all of those of us who want to go and see the hub, because hopefully they'll become important. Yeah. So we should see what they're about.
Let's hope it doesn't break down like the bus.
Well, it won't have wheels, so it won't break down in that way anyway. But yeah, no, that's a really good point. Yes, definitely happy to do that. Excellent. I was just going to mention that in our February meeting we are looking at GP coverage, aren't we, or GP something anyway? GPs.
It's GPs. It is single meeting review. It just put
GPs, okay, because obviously massive issues with GPs. We've got into some of it tonight. But I was thinking that we could add to that primary healthcare coverage in our rural areas. So to basically get an update on the bus and what's happening there in Heathrow villages, and also talk about the issues they've got in Harefield, because essentially the same characters who will be giving us the presentation about GPs will be the ones who can talk about those issues. So are we all happy with that? Yeah, great, fantastic. Yeah, is there anything else we need to discuss?
Well,
yeah, good. You take this one.
So due to capacity limitations during April, we'd like to cancel the meeting in April and reschedule it for May. So we wouldn't be getting rid of the meeting completely. It would just be, normally we don't have a meeting in May, so shifting it in May rather than, so we'll still carry on with whatever it was we were going to do in that meeting, but just later.
So we wouldn't have it in April?
No.
Have it in
May.
Instead.
I mean, we'd probably all be busy with other things, won't we? Probably meeting each other in different places in the borough in April, so I think that's probably okay, isn't it? But yeah, I mean, as we wouldn't have a meeting in May anyway, it doesn't make any difference, does it really? I mean, I suppose if people could email Nikki with any dates they can't do in the next couple of days, because obviously Nikki needs to find a date.
Obviously, it'll be after the election.
Yeah. yeah. So basically, by what day of the week are we? Tuesday. Certainly by Friday. If there are any days any evenings in May that you cannot do, email Nikki, and then hopefully she can find an evening that will work for all of us.
It's got to be before the AGM as well, before the council AGM.
No, it doesn't. It can be after. It can be after the AGM.
My birthday, 26th.
But that's the day you can't do.
If we do it on the 26th, we could have a party after. Oh, we could have a party afterwards. No. I think not being on your birthday is a very legitimate reason not to have a meeting on that day.
Oh, that was yes, it is. Party going on there.
Good, excellent. Okay, so yes, we'll do that and we'll find a date.
Yeah.
Excellent. Okay. Is that everything? Any other comments? No, it's all good. Right, meeting ended, I think.